I was in Hyderabad, Hyderabad. Then I shifted to Mumbai. I was working in Mumbai. I say yes. But then there was time when Papa was also in the factory then he started having some थोड़ा याद होगा तो मेरे को ऐसा लगा कि यार I think I should go back.
Hey, और नहीं बताने का.
Good evening, Kukreja sir.
जी good evening. Good evening. दिल्ली में तो बहुत ठंड हो रहा है. Bangalore must be quite good. नहीं Ravi?
Yes, sir.
Good. Bangalore must be good.
Very cold, very cold. Very cold. It is raining now.
Oh, अच्छा बढ़िया.
So raining, so suddenly temperature still dropped down.
I think my son was there for 1 year in Bangalore. And I visited 2-3 times. And they used to be fantastic.
Yeah.
Round the year.
Around the year, it will be cold.
Delhi में too much of winter and too much of summer, both.
Yeah, correct.
Hi, Shyam. Hi,
Hello,
Chitra.
sir. Hello, Bala, sir.
Hi.
Even Chennai has become cold now this year.
Yeah, this year.
Somebody had come.
Hi, Sitkara. Chennai is.
Sir, good evening.
Good evening.
Good evening, sir. Good evening.
Chennai is very pleasant for a change.
Yeah, for a change this time. Some 2 days back, I met one person.
Yeah.
He told it is very cold, Chennai.
Last 3-4 days, even without fan, we are able to manage, which is a record in Chennai.
Yeah, correct.
So you tend to have a lot of rains in this season also?
Yeah. We have had more rains than usual. This time, rains have been more than the usual. Even today, it was a drizzling. Doesn't happen like this. I don't know. Now, December and all, we don't see rains at all nowadays.
Yeah. Even in Bangalore, it is a drizzling today.
Oh.
So it's London type weather हो गया.
London का weather हो गया.
Chennai is becoming cooler. Bangalore is becoming hotter.
It is a seesaw one between Chennai and Bangalore always.
True.
Sir, we are waiting for snowfall in Delhi.
Welcome, Ranganath Garu.
Sir, thank you. You are all there. I am late, I think, because it is 8:53 only. I thought 9 means you will start sharp 9.
No.
Good evening.
Good evening, sir. Namaste.
So, good evening, Dr. Ranganath.
Good evening, sir. Sir, good evening.
Good evening.
All.
Rashna ji, good evening.
Good evening. Sara
Madam.
Good
evening, madam. Good evening, madam, and welcome.
Yes, all the rains have gone to Bangalore and Chennai.
No, madam. In Hyderabad also it's raining.
I hear.
Good evening, everyone.
Good evening, Chetan.
Yeah.
It has been raining in Delhi also.
Even
Chetan
Ahmedabad also
Chauhan.
there was drizzle today.
Yeah, सारे रेंज यहाँ से नॉर्थ ईस्ट से वहां चले गए.
Yes.
चले गए.
ये लेसन नहीं आया अभी तक.
नीरज जी की कविता है ना कि मेरा घर छोड़ के पूरे शहर में बरसात हुई.
True, true.
तो शायद उनके घर में आ गया और कुछ था होगा.
Jewel sir has come. Good evening, sir.
Good evening, good evening.
Good evening, sir.
Good evening.
Hi, Vijay.
Hi, hi.
So all expert panelists have come, no? 1, 2, 3, 4. And this is super expert forum.
Expert student has come. I don't know about others.
Strict examiner has
Kam-
come. Strict examiner has come.
अरे सर, अरे चेतन दादा, इतना माइकोप्लाज्मा तो कॉलेज से लेके अब तक नहीं पढ़ा जितना लास्ट 3 days में पढ़ा मैंने.
अरे बट किशोर 2 महीने में इतना माइकोप्लाज्मा गए, 35 साल मैंने देखा ना, इतना देखा. एंड दिल्ली में टेम्परेचर कैसे है? कुछ सर्दी वर्दी है?
दिल्ली में टेम्परेचर अच्छा खासा है. इट गोज अप टू आई थिंक 4-5 इन द नाइट.
अरे यहाँ भेज दो थोड़ा बहुत यार.
Go 4, 5.
बम्बई इज वेरी हॉट.
That's why Chitkar sir told we are expecting snow in Delhi.
Yeah, I think first week of January it is quite likely the temperatures would be about 2-3 or maybe.
Is it?
Yeah, that is what's supposed to be, but you never know.
Kashmir has seen very low temperature this year.
Let's have pre-Padicon meeting there.
Okay.
Delhi.
So the only thing which will trouble you is fog.
Yes.
Yeah.
All
But
the flights
since-
must have gone, schedule must have gone for a
Yeah,
toss.
last 2-3 days it was drizzling, so it has become a kind of a moist cold, so it looks quite pleasant, but however the pollution stays around 400.
Mhm.
Good evening, Dr. Nandini, Dr.
Good
Palani
evening,
Raman,
sir.
Dr. Janani ma'am, Dr. Narmada, Dr. Kundu sir.
Good evening, sir. Good evening, one and all the
Oh, you are seen.
expert
Good evening.
doctors. We are waiting for the mycoplasma.
Waiting
Good
for
evening, sir.
mycoplasma?
No, we are waiting for the mycoplasma discussion, sir.
As a discussion.
Reading a lot about this, as doctor said, for the last 2 days.
Okay.
So,
No, why it has increased suddenly? Any idea? Even in Bangalore, I also have got some 5 to 6 cases mycoplasma.
I probably am down with mycoplasma. I give my sputum for PCR today.
Oh,
Okay.
rather you should start azithromycin or
Hello?
rather levoflox.
doxycycline.
Or we will decide at the end of discussion
hear
what
me?
he should start.
Yes.
No,
So
it should be
Vijay,
resistant
you will
because
be
he has
giving.
seen 300 or 400 cases. So he should go to Norflox or
still.
group of
But-
drugs.
So Vijay, you are going to give us first-hand information if you are infected with mycoplasma.
Yes. Are I've been
In
on
between-
antibiotic for
he may cough it
last 6
also.
days. For last 6 days, I'm taking antibiotic. My cough has worsened. It is not able. I'm walking. There is, there is
So
clinical
fitting into
pneumonia.
the walking pneumonia.
Yeah.
Sputum is there or no sputum,
Vijay-
sir? If
Vijay,
it's not,
same here.
Sputum.
if
Vijay,
there is
same
no
here.
sputum, then you
Yeah.
are perfect case.
Vijay,
There
same
is
here.
sputum. Is
There is
it?
sputum.
Okay,
Then
yeah.
we have to think something else.
I think in the last meeting, Vijay, I showed you 2-3 cases of mycoplasma. I think where we met, I don't remember.
Where we met? We met, I think Indore you showed me, no?
Indore.
Indore.
I showed you.
Yeah. By the way, we're having a session in Pedicon also.
On Mycoplasma.
Sham, you are one of the panelists. Christopher is there.
But I have not been informed so far.
I know that is what Jitendra Gavani told me. I have titled it, "Oh Mycoplasma, what are you up to?"
Okay.
So today is a full dress rehearsal for that, my dear.
Today I'm going to learn from Dr. Bala.
Okay, I think it's 9 o'clock and we should start. So, good evening, everyone. I think this is a Super 11 series, 10th link because we missed 1st of January and one in between with Diwali vacations. So now we are again on the 10th link. And because we had so much of discussion about mycoplasma in one of the group of PIDA where academics are they've been discussed, and then the thought came, and that was very well like taken up by Dr. Bala sir, Dr. Vijay Ule, and we decided let us go for current affairs series because that's also going on. But then we thought why not to go for Super 11 only. So here we are going to discuss mycoplasma, and I'm thankful to Dr. Bala sir, Dr. Yule sir, Dr.
Super 11 सुझाला mycoplasma आता just.
Kukreja sir and Dr. Chitkara sir for agreeing to be part of this expert panel. So as this is going to be a last in the series of this Super 11, I'll request first our chairperson who will be outgoing chairperson for PIDA to welcome and address everyone. Dr. Darul Rangnath sir.
पीड़ा से बाहर नहीं, पीड़ा में रहेंगे और 1 साल रहेंगे एज पास्ट चेयरपर्सन. हर मीटिंग अटेंड करेंगे, हर सीएमए अटेंड करेंगे, देखेंगे कितना होता है दुनिया में हमारे बाद में. सर, so that is about the short saying, but literally the burning topics were concentrated and tried to analyze them. So this deserves definitely, mycoplasma deserves a better discussion. So this is the time, this is the day where we are planning to have the discussion on it. All the best. And the faculty is not a small people. They are all experts with more than 40 years of experience, and they can simply differentiate on clinical grounds itself, which is mycoplasma, which is not mycoplasma, and how to treat and when to do investigations, and how long it is going to last, and how can it be identified. All these things will be dealt today. All the best to the panelists and the moderators. Thank you.
You all will be surprised like this time we don't have any moderator. So because being a mycoplasma, it is what we understood is it is everywhere. As Dr. Ravi Shankar was telling, it's in Bangalore, it's there in Chennai, it's there in Mumbai, it's there in Ahmedabad. So I think we left up to all the 4 expert panelists, and also we have Dr. Kundu sir also there. And so we have expert forum, and they'll be discussing at their wish and will. I'll request Dr. Vijay Ule sir, Bala sir, Dr. Chitkara sir, and Dr. Kureja sir to start the discussion. Thank you so much. Yule sir. No, you are not audible.
Unmute.
No, he is unmute, but maybe the AirPods are now been connected, not connected. Now you speak. No. Speak something, sir. Hello.
Vijay, stop using earpods.
So that means he is listening to it.
Yeah.
So AirPods are only. हाँ.
Yes, go ahead.
नहीं, it has stopped. Sir, speak something. No.
So you are not connect. Just try once again, disconnect and connect, sir. Vijay will listen.
Bala sir, can we have an opening remark from you? Till Dr. Vijay Vale
Yeah.
joins?
Yeah. Am I audible?
Yes, because
Yes,
sir.
this,
Okay.
you know that this is Super 11 series is your brainchild. So
Okay. Now, thank you, Chetan. Thank you all. We have a very distinguished panel today with 3 Super 11 batsmen waiting to bat. And I thought I will just open the bowling and try to bowl fast in next 12 to 15 minutes. Chetan, can you allow me to share the screen?
So you can share.
Okay.
You can share, sir.
Okay.
Yevle
Okay.
sir, are you there?
Now, okay. Is my screen visible?
Yes, sir.
Yes.
Okay. Now, I thought that this is a very unique webinar, which has been planned by Dr. Daruru and Dr. Chetan. I thought we must first have the objectives of this webinar in place before we start discussing, because we have 3 experienced batsmen there waiting to score sixes and fours. So let's see what the objectives should be. Whoever is listening must understand the epidemiology of Mycoplasma pneumonia, which is very unique, I thought. And we, as pediatricians and clinicians, we should be able to recognize the clinical features of Mycoplasma. And we must know how to diagnose, when to evaluate, how to evaluate. And of course, most importantly, how to treat and when not to treat, and when to change antibiotic, when not to give antibiotic, etc. Be very interesting to know Mycoplasma has been there, this organism which doesn't have a cell wall and which doesn't respond to beta lactams. We all know from undergraduate days. It's a very common cause of URTA and LRTA both. It's a very common infection, but people are saying that we are seeing more and more pneumonia these days. Books and journals say that 10% of children who are infected will develop pneumonia. I believe adults are less prone for pneumonia than even adolescent children. Preschool children, Mycoplasma everywhere in the world, the incidence is less. It's got a long incubation period, mostly 2 to 3 weeks, and it can come in epidemics. I mean, Mycoplasma, so much is there about Mycoplasma from China, Japan, Southeast Asian countries, but hardly much data from India. If you look at what is known in India, in a beautiful review article from Indian Journal of Medical Research, I got the statistics. It has not changed over the last 4 years also. Majority of papers from India suggest that Mycoplasma pneumonia is responsible only from somewhere between 16 to maximum of 35.5%. The problem is that this data is not uniform. One paper says it is 24% based on culture, serology, and PCR. Another paper, serology and PCR. Another paper, it is not mentioned how they arrived at diagnosis, mostly IgM. Another paper, everything has been taken. So there is not much of uniform data, but we know that our incidence is much less than China and Japan. Okay, let us move on to a sample case, which I'm sure everybody is seeing now. 9-year-old, she had some cough, rhinorrhea, and the good pediatrician sees and says it is viral URI, but the cough worsened, and again, child is continuing to have fever. Now the illness has come for has been there for 10 days. Fever is there. She has hypoxia. She looks well, not in acute distress, like Evele said. We know she is walking, but she is hypoxic. She has the red pharynx, some nasal discharge, some crackles on both sides. And of course, what are the considerations in management? What should be the basic approach? Well, you're going to think of atypical pneumonia at this point of time because there had been some illness for 2 weeks and crackles are there. An X-ray is taken. And look at the X-ray, it shows some perihilar infiltrates, both sides, some retrocardiac changes on the left side, minimal air bronchogram, paracardiac infiltrates. It's not a typical lobar consolidation, bilateral interstitial markings, but she is hypoxic and clinically she is tachypneic and we know she has got pneumonia. Now the question to the pediatrician, is this atypical pneumonia? The next most important question I have is, should we test for mycoplasma or not? And if tests are planned, what tests are appropriate? And I'm sure none of us will withhold antibiotics to somebody who has had 2 weeks of symptoms with hypoxia. We don't have the guts to say that when there is no V's, we are definitely not going to withhold antibiotic. And which antibiotic am I going to give? Is it beta-lactam alone? Commonly, we all prescribe amoxiclav because the standalone amoxicillin injection is not available. Or we give a cephalosporin if the patient is hospitalized, severe pneumonia protocol, ceftriaxone. And the next question is, she is 9 years old. Should we give beta-lactam alone or should we add beta-lactam plus azithromycin? Or should we give only azithromycin on a clinical diagnosis of mycoplasma atypical pneumonia? And how do we decide? That, I think, are the dilemmas which we are going to discuss. This is another case where a girl came with a pneumonia like this, with 3 to 5 days of cough, fever, etc. The primary pediatrician took an X-ray and he saw the consolidation on the left side. He rightly prescribed amoxiclav, good dosage. And 3 days later, on day 6, look at this. This child developed Stevens-Johnson syndrome, classic Stevens-Johnson syndrome. And the parents blamed the doctor that you are given amoxiclav. And we went through the records and we found out this child has received amoxiclav any number of times. So we knew that this is not amoxiclav-induced Stevens-Johnson. And with this pneumonia, which has been going on for nearly a week, we thought it could be mycoplasma. This is about more than a decade back when we had only mycoplasma IgM available for us. IgG was also available. IgM was positive. Unfortunately, we could do 2 paired sera of IgG and there was a 4-fold rise. And this is a case of proven mycoplasma with Stevens-Johnson syndrome. Those days, we didn't have PCR at our disposal. And look at this child who had pneumonia and who had rashes like this. Then you must remember that 10% of cases of mycoplasma pneumonia have a cutaneous manifestation. And I took this slide from the American AAP website where, they talk about extrapulmonary manifestation. But what is new is that a new terminology has been introduced in mycoplasma. That's called MIRM. That is mycoplasma-induced rash and mucositis. That is, more than 2 sites of mucosal involvement can have only mucositis. And it's not easy to diagnose because somebody is going to think of Kawasaki, somebody is going to think of Stevens-Johnson syndrome, de novo, herpes simplex, etc. The other extrapulmonary manifestations are well known are hemolytic anemia, Coombs positive, CNS manifestations, any itis can occur, and of course, similarly, myocarditis, pericarditis. The biggest problem is the diagnosis of CNS manifestations because you may not get the PCR positivity, you may not get even IgM positivity in the CSF, but you will get only IgM positivity or PCR in the throat swab. Next case, this child recently we had where this boy who had pneumonia like this with pleural effusion like this, he went on and on with 15 days fever. The outside pediatrician had given good dose of cefotaxime. He has given azithromycin for 5 days. He also gave clarithromycin for 3 days. He started on oral linezolid. We hospitalized the child. And this was actually a we thought it is a necrotizing pneumonia based on the CT and the X-ray. We put him on ceftriaxone and clindamycin. He didn't improve. Of course, this is the fever. This is the fever pattern on ceftriaxone, clindamycin. Blood cultures are negative. And the ultrasound and the CT said you will not get any fluid, very minimal fluid. But we ventured. At that point, we didn't know what to do. And we ventured to do a pleural tap. And this is the straw-colored fluid which we got. Of course, we also thought of tuberculosis. We did investigate for tuberculosis. And once we got the fluid, in addition to cultures, we also sent it for metagenomics, PCR, and 16S RNA, because we didn't want to miss this sample. We knew that it could be due to an unusual organism. And incidentally, we also got free of cost an nasopharyngeal aspirate for mycoplasma, which is actually positive. Nasopharyngeal aspirate positive, pleural fluid like this, non-responding pneumonia, macrolides given for nearly 8 days. And we sent the pleural fluid, which is used for 16 as RNA, and heavy content of mycoplasma in the 16 as RNA was reported. And they also did the sensitivity. To our surprise, it was sensitive to everything. But this child did not respond to azithromycin. So we started levofloxacin, 8 milligram per kg BD. Exactly in 48 hours, everything cleared. Miracle. The moment you started. That I'm not saying that we should give levofloxacin for every case. This child, we had the choice of giving tetracycline or choice of giving a levofloxacin. But we chose levofloxacin and we got a very good response. At this juncture, I thought we should share our own data on PCR and IgM and mycoplasma pneumonia, which we recently published. Our prevalence of mycoplasma pneumonia and community-acquired pneumonia was 15%, much lower than the Western series. Okay. And most of them were PCR positive, and PCR picked up cases where IgM was negative. So we concluded that early diagnosis of mycoplasma pneumonia could be helped by real-time PCR if you take a good nasopharyngeal aspirate swab and send it. And this, in cases which received antibiotics, PCR negativity was frequent. So you should do PCR as far as possible before we start macrolide or doxycycline. That's what we concluded. In fact, at this point of time, I would like to share one interesting study which was published in PLOS Medicine, where some crazy fellow, what he did, he took up the task of doing mycoplasma PCR in asymptomatic children and children with RTI symptoms, 3 to 16 years. And mind you, this crazy fellow, he found out that mycoplasma PCR was more positive in children who are asymptomatic than who are symptomatic. 21% of normal children had PCR in their throat swabs positivity. Whereas in pneumonia and LRI, he found out only 16% had positivity. So I am sure this will come up for discussion, and I am sure you, the experts will have comments on this paper, as well as the interpretation of positivity of PCR in a throat swab or a nasopharyngeal aspirate. And there are several controversies which I'm sure all the three experts will address. This slide again is from AAP website, from Pediatrics in Review. Testing is controversial. In fact, when to test, when not to test. I am of the firm opinion, outpatient practice, you should treat rather than test. Inpatient practice, if you want to start specific treatment, it's better to test. And of course, the tests that are available, we all know, antibodies, IgM, PCR, cultures are not available, and new generation PCR studies and 16S RNA. And last but not the least, fourfold rise in titer of IgG, which is supposed to be one of the gold standards for diagnosis. Treatment, but WHO, we all know, has not included macrolides in the algorithm for pneumonia anywhere in pediatrics. The reason is there is no data to suggest that macrolide treatment or treatment for mycoplasma helps in children who are not very ill. Ill children, I don't think we should withhold treatment, but of course further studies are required. With this, I thought I'll wind up and quickly run through the questions for Dr. Chitkara, who volunteered to steer the discussion, and to Vijay Vele, who has some cases, who has seen, I believe he has seen 100 cases. I'm sure he'll have more searching questions than what I have. But the questions I thought that all of us should be trying to answer are: when should we investigate? What is the gold standard for confirmation? Bullous meningitis, I have seen 1 or 2 cases, but I have treated them only with amoxicillin or amoxiclav. Is it synonymous with mycoplasma pneumonia? Cold agglutinin test, in fact, even in CMC value, they continue to do it. I would like to ask the experts whether it is useful or not, whether they are doing or not. And lab clues, CBC, CRP, LDH, ferritin, do they help? X-ray, what are the findings you can get in mycoplasma? Can you get anything? Are there any specific findings? And IgM, is it a useful test or a useless test? What's the specificity, sensitivity? In fact, most of the audience who are in small town will always be doing only IgM for diagnosis. What is the advice for the experts? What about IgG? Which should you do? Nasopharyngeal aspirate or a throat swab or a sputum? How reliable they are for exclusion of mycoplasma? And last few questions, very challenging. China and Japan are reporting 90% resistance to macrolides. Hardly any data in India, except anecdotal reports, which I just showed you, where it is showing azithromycin sensitivity, but child did not respond. Do you think we can consider doxycycline as first-line therapy now in India? How do you confirm the resistance? And what is refractory pneumonia? What about the use of levofloxacin or doxycycline for therapy? When do you use it? Do you do LDH and ferritin? Are you going to think of refractory mycoplasma or immune-mediated syndrome in mycoplasma and use steroids or IVIG? These are all the 11 questions to the Super 11 trio. With this, I'll wind up and throw open the floor for discussion. Over to Vijay, Chitkara, and Kukraja. Thank you very much.
Okay, thank you, Dr. Bala, for that good opening, session where you set the ball rolling. A few things that initially you talked about the prevalence and incidence of mycoplasma, what is scanty literature that we have in our country, from our country. I'm sure all my colleagues would agree that there is no doubt that we have been seeing mycoplasma for last several years, but we never bothered to test as much as we have started testing now, number one. Number two, we, ever since the molecular test came to our disposal, BioFire and other, the ICU, critically ill children with non-responding pneumonias, wherein either a nasopharyngeal swab or a mini ball or a ball samples were tested for different DNA of different pathogens, and detection of mycoplasma did help us in practicing antimicrobial stewardship. However, there is no doubt that there is an unprecedented outbreak of mycoplasma seen at least in Mumbai, Navi Mumbai area. And Sham tells me that they also have seen a lot of mycoplasma in Delhi. Ritabrata expressed that in East also they are seeing. You have been seeing in South. So there is an outbreak. Now, if you look at the literature and the latest reports, there is also is known to occur every 1 to 3 years. There is cyclical, surge. Following COVID-19, because of the non-pharmacological measures, the incidence and prevalence went down. But for reasons not very clear to anyone, there is a delayed surge we saw surge in almost all respiratory illnesses by different pathogens, viruses, streptococcus pyogenes, and now we have mycoplasma outbreak. Typically, peculiarly, this mycoplasma surge has occurred after gap of almost 3 to 4 years, and it's seen all over the world. The European group of microbiologists who are studying mycoplasma epidemiology, if you look at their publications, there is a clear-cut statement that almost all countries, European countries, world, they are seeing a lot of surge in case of mycoplasma. Secondly, though we talk about very low incidence and prevalence from our part of the world, we have hardly been testing and documenting mycoplasma. And all of us clearly understand the limitations of serology, which could be either IgM or cold agglutinin, or not putting the molecular test to rampant use for the valid reasons. It would be incorrect to say that we did not see mycoplasma in the past as much as the other neighboring countries saw. There is no reason why all Asian countries, if they are seeing a lot of mycoplasma, why it should not be present in our country. So there is no doubt that mycoplasma does exist. Now, coming to today's discussion, I mean, Sham, Chitkara, do you have anything to add to this? Do you agree that are you seeing a lot of patients of mycoplasma in your part of the country? Sham, unmute. Sham, unmute.
Sham,
Unmute, Sham. Can't hear.
We
Sham,
see
unmute, please.
every year we see some sporadic cases. This year we saw, I won't say outbreak, but see good number of cases, maybe more than the normal what we see. Maybe I saw something like 10, 15 cases in last 2-3 months, and which were classically fitting into mycoplasma pneumonia. So yes, we have been seeing these cases. And if Dr. Bala remembers, I had presented one case in Chennai in his hospital, where one of our patient was not responding to azithromycin, and it was bilateral pneumonia, and ultimately we had to give levoflox, and only then the patient responded. And this patient was there with us for 10 days. We struggled to treat this patient. So we keep seeing patients off and on. Yes, Dr. Chitkara must have also seen. Dr. Chitkara?
Yeah, so like earlier I said, I have never reviewed mycoplasma in Indian context right through my college till 3 days ago. And I have, Dr. Bala, there is no dearth of data on our respiratory pathogens. And you quoted something from your KKCH. You have a good study from ICH. I am told there's ICH in Madras. And then it was a study, clinical as well as a pure applied microbiology, and it was very revealing. In 2019, we have another report from Maulana Azad Medical College looking for, this was G.R. Sethi was one of the authors, looking for this. See, I say if you consider Super 11 or otherwise discussions on various forums in 23, similar kind of presentations, prolonged intractable course, we attributed to adeno. And I'm sure you all remember that. And adeno was the flavor of the 2023. This year, probably we have developed more interest. Am I audible?
Yeah, you're audible.
So this year we developed additional interest in mycoplasma because somehow, there was a Chinese outbreak, and then All India Institute of Medical Sciences followed by just 7 cases of mycoplasma, which was more reported in national dailies rather than any of the medical journals. So when I reviewed data from South India as well as Gulshan Sethi's study, see, we have anything between 12 to 30% evidence of a mycoplasma. So mycoplasma has always been there, except that we have been more aware this year following international reports of mycoplasma being there. That's number one. Number two, the biggest change I find in anything after 2015 onwards is we have always attributed to a CAP, a CAP in children more than 5 years, where Mycoplasma conventionally we have considered as one of the significant pathogen. Now, these studies which were in 23, 22, 2019, 50% of these Mycoplasma were positive or below 5 years. And surprisingly, less than 30, around 36% were in infants. So this was a surprising change, whether it is an epidemiological change or whether it is our testing methods. See, 11 questions, Bala, you raised will never have perfect answers because Mycoplasma is actually an enigma. We treat it more by conjecture. And after, since I was told that we are having a discussion on Mycoplasma, I rang up certain colleagues in various hospitals in Delhi. They have seen Mycoplasma, picked up Mycoplasma in more frequency that we did in the last few years. But it has not been like an outbreak like Sham says. So and then I rang up our central max where 5 centers across Delhi send their respiratory PCR samples. And according to him, there has been a spurt, but not a kind of an outbreak which is causing literally problems. So that is what Sham has also said. So then I also sat down and fished out some statistics from my institution, which are very interesting. And to tell you that, if you allow me for 1 minute, I have just a slide. I will not put it on the system. 2,100 OPD visits in last 3 months. I'm saying this actual data which I analyzed this morning. 103, something, a term which we used in yesteryears, Walry. Prolonged course, lot of chest signs, but not much clinical symptomatology. A few of them with respiratory distress and not maintaining saturations. So 103, where I wrote Walry, which is a term which is no longer used, actually denotes the clinical symptomatology of a suspected mycoplasma. Prolonged course, lot of chest signs, some distress, but not really sick enough. Out of this 103, we did 34 chest x-rays. And there were only 3 consolidations and 28 were infiltrative or the interstitial, which is like what you describe, Bala, as class 2. Which can be because of any of these viral infections, we cannot just challenge. However, there were 11 otitis media in these patients out of 34. So these 11, where we diagnosed otitis media, we put them on beta-lactam, amoxiclav. Rest 22 received azithromycin, no hospitalization. And this was OPD. When I come to indoor, we sent 108 respiratory PCR during this year. Only 1 mycoplasma was picked. Viruses predominated, especially RSV, rhino, and influenza B. And 3 mycoplasma serology were positive. And they were correlating with the clinical presentation. There were 10 alveolar consolidations, 3 lobar, and 6 mnemonic effusions, which really did not merit any tapping or a pleural fluid to be withdrawn. And all of them, like our CAP guidelines, were on beta-lactams. In 23, where we suspected mycoplasma, but the evidence was only 1 positive and 3 serological positive, had beta-lactams plus azithromycin. And all of them recovered. So this is a distribution of 2024 of indoor and outdoor. So I would say we are suspecting more mycoplasma. The evidence, however, is not that confirmed because there is no gold standard for detecting or confirming a mycoplasma. That's from me. Thank you.
So I would like to put one thing that I would, yeah.
Yeah, 1 minute, Jay. In fact, interestingly, what Chitkara said is very pertinent. In fact, after we decided on this webinar, 2 days back, I searched the net for a with a question to AI: is Mycoplasma incidence increasing? And I got very interesting answers from AI and also from my friend in UK. In fact, in the United Kingdom, I believe over the last 3 years, the identification and reporting of Mycoplasma has gone up 100%. And in the website, it is mentioned, I went through the records in the NHS website also about this. It is clearly mentioned the reason for this exponential rise is not truly an increase in incidence. It is because nowadays, Mycoplasma testing is not confined only to serology. It also includes PCR. So I believe in European countries, as well as in countries like Japan and China, they are reporting more and more cases of Mycoplasma, mainly because of adoption of nucleic acid amplification tests and not relying on serological tests or antigen tests. So, I mean, in India, the same thing is very likely to happen. If we keep testing for PCR for Mycoplasma, I am sure we will find over the next few years increasing incidence. In fact, even in 1985, 88, I remember there was a Dr. A. Balachandar had published about Mycoplasma. 25% above 5 years had Mycoplasma antibody positivity. 25%, which itself is very high, which is lower than 15% in our series. So I don't know whether the so-called increase which all of us are seeing is truly an increase or increase in testing, increase in identification. We can't be very sure. And in fact, Chitkara, your figures are very encouraging. It suggests that Mycoplasma is not a big threat in Delhi. But I'm sure Vijay will have completely different data.
I mean, I don't refute what Chitkara is saying, but trust me, in Mumbai, not only are we seeing Mycoplasma, we have seen other cases also. And where there was high pre-test probability, those patients we tested, and not only PCR, we are putting a lot of serology also on the, which would corroborate well with the clinical findings. A child who has fever for 6-7 days, coughing, but not very sick looking, and you have a patch on X-ray, and you do Mycoplasma, the serology, the titers have been more than 27 and 36. So we have never seen this kind of titers in the past, number one. Number two, we did, subject a few patients to PCR also, where PCR has come positive. So there is no doubt whatsoever that there is an increase in Mycoplasma in Mumbai area. That is one. Secondly, unlike what we believed in the past, that Mycoplasma would come typically in school-age children with non-specific infiltrates on X-ray, is no longer valid. We have seen it across all ages. We have seen lobar consolidation. We have seen patients coming with sympneumonic effusion, empyema, and in fact, the Mycoplasma, you suspect Mycoplasma if there are extrapulmonary manifestations like arthralgia and transaminitis, we hardly see. I mean, at least I have not seen many such cases. So, I mean, there is no doubt that the only reason why I wanted to discuss this here on this before I called up Chetan is a lot of knee-jerk reaction is occurring everywhere. Think that if there is no response, think of resistance and change to doxycycline alone. We need to be a little careful because there is no evidence as on now to say that there is macrolide resistance to to our Mycoplasma in Mycoplasma. I'm saying so because we have had at least 5 cases where we have proven co-infection, either strep pneumonia, staphylococcus in one of the patients. 2 patients have strep pneumonia associated co-infection strep pneumonia. We had 2 patients with influenza, and there the clinically also it did fit with Mycoplasma. So just to have a knee-jerk response and say that, oh, this non-response is because of macular distance would be absolutely incorrect. So this is one point that we must drive home. And now coming back to different question that Bala has raised, if you allow me, I will share my presentation and show you cases. And those cases, we can take all these questions that Bala has raised. Is it okay if I share my presentation?
Yes, please. But
Okay.
just a line
Yeah,
before
yeah,
you start, Vijay. I think
yeah,
upper
yeah.
respiratory PCR, which is being increasingly available, is the real culprit
Yeah.
for whatever bugs
So
we are
I'm
reporting across years and different kind of presentations at different times. Over to you, Vijay.
Yeah, I'm not talking about this thing at all, PCR. I told you, serology, which we have been doing in the past also for suspected mycolo. Is my presentation visible?
Yeah, it's okay.
Can you see
Make
the presentation?
yeah,
Yeah,
make it
okay.
full field.
So,
Make it full
so
field.
I'll run the slide.
Yes.
Okay. So this Dr. Bala has already alluded to smallest self-replicating organisms as a reduced and highly stable genome, and it lacks cell wall that he already said, slowly growing. And I had a word with Dr. Kamila and Dr. Balaji also. So we have not been culturing this pathogen because, by the way, Dr. T. Jacob John was the first person in the world who cultured Mycoplasma, and it requires specific aerophilic system, which is very costly system. And laboratories do have this kind of a system where they do viral isolation. But they say if they, make an attempt to grow mycoplasma using this the whole system would get contaminated. They will have to dispose it and then again invest fresh in. So it is not a cost-effective thing in today's world. So nobody does culture. Now, since there is general pediatricians who are attending this webinar, I thought let us walk through what we come across in practice before we, embark on to discussing mycoplasma specifically. Now, this is a 3-year-old child, has cough for 2 days, there is no fever, is on azithromycin and oral salbutamol, and he comes for persistent cough. On examination, you find that he is afebrile, he is active, has bilateral wheeze, and there are a few crepitations. And we know that a child who has fever, cough with or without breathlessness or rapid breathing is a very, very common problem. Now, I want to ask each one of you, how do you tackle such situation? Leave aside mycoplasma. How do you approach? Because this is the commonest scenario that a pediatrician comes across in his practice. So how do you handle these kind of children in your practice? What dictates your testing? What dictates your clinical diagnosis, and how do you decide on using an antibiotic in such children? Who would like to do this? Sham?
Yes. uh, I think I'll take it the whole subject in such a way that how you suspect mycoplasma in your daily practice. That's the question you want to know. That's right. So I'll
Not
put it
only
like this.
mycoplasma, this is a very common scenario which is
Yes,
seen day in
absolutely.
and day out by every pediatric.
Absolutely. I think you can
And this is where
see more
a lot of abuse
mycoplasma
happens.
if you think about it. Otherwise, there's no mycoplasma. So I believe that way. See, that this depends, number one, of the age, as Dr. Bala was saying. You see, after the age of 4 or 5 years, less than 4 years, most possibly you don't see. The reason being, it is something like hepatitis A, that host doesn't sort of react too much to mycoplasma. And even if it is there, if you treat or don't treat, doesn't matter. It's only an occasional sick patient where you need treatment. So it's something like this. So, and there are more viral infections in up to 3 or 4 years. And that's why I think mycoplasma is absolutely low. It is more after the age of 4 or 5 years. Now, what in my practice I do is I consider age, then I see clinical presentation, and then epidemiological factors. Like if I am seeing some cases which are fitting into this, I have my antenna up that I may be seeing mycoplasma. Then second is, Vijay, you must have seen the duration of symptoms till the time becomes sick is longer in mycoplasma. It is something like 6 or 7 days. In general pneumonias, it is 3 or 4 days, maximum 2 3 days. So it is something longer. This is what I have seen, which is classically described as a walking pneumonia. The child has come, the fever is not much, 100, and he is having cough, which is going on. It's non-productive cough in the beginning. And the child is otherwise okay, coming to the clinic, little fatigued, and maybe complaining of headache. And this is another presentation. And you put your stethoscope, you find crackles on one side, and you suddenly feel, oh, I may be dealing with this Mycoplasma pneumonia. Then, as Dr. Bala has shown, skin rashes, maculopapular rash with the chest signs. Again, you start thinking in these terms. Then we have seen cases where there's a fall in hemoglobin, and you suddenly think, oh, yes, this pneumonia and fall in hemoglobin, this could be mycoplasma. And if you happen to do Coombs test or maybe cold agglutinin, you'll find it's positive. Then Rolex formation. Our pathologist will tell us, आपके इसमें दोबारा sample भेजो, ये तो सारे RBC clumped लग रहे हैं. So then you start thinking, oh, I may be dealing with this. Then I tell you one very interesting thing. We had a child where there was an absurd CBC. See, what was happening in the CBC? Hemoglobin is around 10, MCIC is 60, RBC count is low, and the explanation was cold agglutinins. So sometimes even your CBC will give you an indication. Once there was a child who came with pneumonia, and the child was having low hemoglobin, and the blood bank tells me, sir, मुझे cross batching की difficulty हो रही है. Then you know, yes, this is definitely going to be mycoplasma. And I think we should always start thinking of mycoplasma if there are CNS manifestations with it or the skin manifestations. Any community acquired pneumonia admitted and child is not improving, I think in this patient, you must think of that you may be having this. And the last one is, I think, non-responsive pneumonia, which is going on to ventilation. I think start thinking in terms of maybe IVIG and steroids, because these are the cases, maybe there's an immune mechanism which is going on. So this is in summary, I can tell you my experience of seeing these Mycoplasma pneumonias. And coming to your question, which I've summarized, if a child has come with fever, cough, rapid breathing, and this child needs to be admitted, there's a one group of patient with no rapid breathing and these symptoms are there, I'll definitely give in this case azithromycin and watch. But if the child has got the rapid breathing, I need to admit this patient and treat as a community acquired pneumonia. And depending on his pocket, I may test, or insurance, I may test for mycoplasma, because the biofire costs something like 20,000 rupees. So I'll give a beta lactam with the azithromycin and treat this patient.
So very well brought out by Sham, the pointers that one must keep in mind to think of making a clinical diagnosis of mycoplasma, and a few laboratory tools which come to our rescue and help. But the point that I wanted to make is almost each and every patient seen by almost every pediatrician who presents like this, many of them are viral infections, but
Vijay,
almost majority.
Just hold on there. Now here you want to differentiate between viral and mycoplasma. See, again, the viral, the lot of family members may be having cough and cold. Rhinorrhea is not a very prominent symptom in mycoplasma. It may be there. It may be there. It's not a very prominent system, but is a manifestation. It's very common in viral. And the viral children become sick in 3-4 days. They don't take 7-8 days for that. And they have lot of wheezing and all that. Wheezing can happen in mycoplasma, but more common in viral. So you have to see all these factors. And the age is 3 years. I'll be more putting my money on viral rather than on mycoplasma.
Absolutely. So this is the point that I wanted to make, that most of these children, one is they get antibiotic, and majority of them are viral. The repeated, these associated viruses that we see in clinical practice. Younger age group, they have bronchiolitis. I mean, honestly speaking, these are not very difficult diagnoses to make, but somehow this kind of upsurge in mycoplasma, I have seen that almost every patient is getting azithromycin. The day I put that there appears to be clustering of cases of mycoplasma, the azithromycin prescription has gone up manifold, So once a day course, short course, And then somehow, I mean, we need to refrain from using azithromycin for every patient who presents with respiratory complaints. And not to forget that even for pneumonia, it is not the drug of choice unless you have atypical pneumonia, which one can suspect based on what Sham alluded to. And azithromycin for bacterial RTI needs to be used only in patients where you have type 1 sensitivity to beta-lactam. Otherwise, we
If I
must
can add
avoid
in
using
your slide,
azithromycin.
just go back
Yeah.
in this slide. If I take bronchiolitis, this is in the age group of less than 2 years.
2 years.
And cough is not a predominant symptom. Fever is not a predominant symptom, but the breathing difficulty is a predominant symptom. Child may not be very sick, but having a lot of tachypnea. And not a minimal cough, because bronchioles do not have a lot of cough. So their presenting symptom is breathing difficulty. Pneumonia. Fever is the predominant feature. Fever
And they
is
look
the main
sick.
predominant feature. Cough comes little late, and minor cough may be there. Mild cough may be there in pneumonia. Asthma and Wallery, cough is a predominant symptom. In these two cases, the cough is number one because both are involving the bronchi. So they have a lot of predominant symptom. And if you take chlamydia and mycoplasma, they are interestingly such bugs which cause upper respiratory, they cause lower respiratory, they cause the involvement of bronchi, they cause involvement of parenchyma. So they involve everything. But they again not very sick children. They are having temperature less than 101, 102. So this is how clinically you may differentiate between all 5, 6.
My plea to all those who are attending, please, try and imbibe these pearls of wisdom which Sham has been saying, and please refrain from using it. And it's not very, very difficult to, differentiate one from the other. And please have a very high threshold for using an antibiotic, and especially using an antibiotic like azithromycin, because ultimately it is the abuse which will lead to resistance in future, or if it is at our door, we really do not know. Chitkara, you wanted
So,
to say something.
referring specifically to this case of 2 days duration with wheeze, I think most of my audience should remember that this is a viral wheeze in a preschool or a preschool viral wheeze. And I do not know, Wallery was such a good term to describe the pathophysiological event in such a case, which has been withdrawn. Otherwise, these patients never require any antibiotic, and just supportive care and some nebulization with the short-acting beta agonist, and that should suffice. So I think in such a short-term case, there should be no suspicion of mycoplasma. There should be no attempt at any of the antibiotics, except if this similar course, like Sham said, gets prolonged over 6, 7 days and is not responding to the conventional supportive treatment in the form of SABA or some antihistamines we give. So that should be a clear message in this particular case.
Absolutely, I cannot agree more on
come
what
in?
you both
Can
said.
Vijay,
Dr.
can
Bala, please. Yeah,
can I come
please,
in?
please come in. Yeah.
Two or three important points in this case. One, 3-year-old, wheeze is there, whether there is fever or not, my pen should resist writing azithromycin or even antibiotic for that matter. That's one.
Absolutely.
Two, using azithromycin for pneumococcal pneumonia is criminal in a 3-year-old. The reason is azithromycin will not be, even if the pneumococcus is macrolide sensitive, majority of under 5 pneumonias are bacteremic, though we don't pick up cultures. And any bacteremic pneumonia, even if the pneumococcus is macrolide sensitive, azithromycin will fail. We should not be using. 3, in a 3-year-old child, any outpatient, wheeze or no wheeze, if I'm going to treat the patient as outpatient, I should not consider using azithromycin at all. But there is enough data in literature that uncomplicated URTI or LRTI, when I'm saying uncomplicated means non-hospitalized, no hypoxia, no severe respiratory distress. even if you prove, if somebody happens to do a mycoplasma PCR for this patient, even if the PCR comes as positive, if I don't prescribe azithromycin, I can defend myself in court saying it doesn't do anything at all. It is not known to alter. Only in severe mycoplasma pneumonia, antimicrobial treatment helps. In such run-of-the-mill outpatient WALRI or VAW, azithromycin should go to the dustbin and not to the patient. Thank you.
Absolutely. So the purpose of putting this case was this is the syndrome that all of us see in practice, and this is where a lot of clinical reasoning needs to go in, and one must refrain from using antibiotic indiscriminately, and more so azithromycin. Now, having said that, now let's move on to discuss a few patients that where I really had difficulty, and with these cases we'll take up all the questions which have been raised by Dr. Bala. Now, this is a 10-year-old child seen a pediatrician for a short duration fever of 2 days. This pediatrician started this child on amoxiclav. Now, 48 hours later, this is the CBC, not really very conclusive. CRP is 19, and Vidal was done, which was 1 in 160, both O and H. And this child was started on cefixime. And then this child came to us. On examination, this 10-year-old child, he came last about 15-20 days ago when a lot of mycoplasma is in the air in Navi Mumbai area. Now we just got his counts repeated. The CRP had come down. The counts were around 10,000. This child had V's and crepitations on the left side. So clinically, he had pneumonia, but he did not look very sick. Now my question is, this count of 9,000, 10,000, CRP of 19, which is not very high, though we know that the sensitivity of these parameters is not extremely good. However, higher the CRP, higher the count, more likely that it could be bacterial is the general understanding and reasoning that we do in clinical practice. And look at the consolidation which is seen on the left side of the chest. Now, my question is, how would you treat this? This child now has been having fever for 5 days. 10-year-old child, clinically not looking very sick, but there are crepitations on X-ray. He's wheezing also. And would you treat this as mycoplasma? What antibiotic will you use? Will you test this child? And so what will you use? Will you use azithromycin on this child? That's my question. Any one of you can take this.
Yeah, see, these are the scenarios which I said sometimes confuse a pediatrician. Now, after whatever amoxiclav you have used and you have some non-specific infiltrates in your X-ray, and there are a lot of respiratory signs, at the same time you say that the patient is not that sick looking or the saturations are not dropping. However, I must tell you that CRP is a very non-specific, and especially when we take mycoplasma, CRPs really don't increase much because CRP doesn't really invade the system. Whatever extra pulmonary sign symptoms we are getting or findings are most of immune mediated. So therefore, you don't really have all those inflammatory markers which are high unless the immune mediated damage becomes very important. Now, like I said, a kind of a Walry with a prolonged course in present scenario with mycoplasma deep set into our minds, one may consider, but still it could be jolly well an adenovirus. It could be jolly well another virus, especially those rhino and enteroviruses, which could cause. So unless the child appears quite sick and should be on a close follow-up, rather than consider mycoplasma. But however, I would still resist putting on azithromycin unless, like you are saying, that you are having lot of evidence for mycoplasma in Mumbai, then I may be tempted to use azithromycin. But however, in Delhi, with the statistics I presented, probably I'll hold myself. So that is what would be
Chitkara, your points are well Chitkara, points well taken. But a child, 10-year-old child, 5 days fever, has crepitations, not very sick looking, but there are lower respiratory tract infection signs, and there is a definite evidence of some consolidation seen on X-rays. Would you leave him alone, saying that this is viral and let it heal on its own, especially on the background that we are seeing a lot of mycoplasma?
Don't leave alone. Close watch, follow up daily, even if it is in the clinic. I do understand there are financial considerations, but since these are cases which we don't need to see them morning, evening, and then every time charge in a private sector, but we are concerned. Definitely, there is a concern. And with your epidemiology in Mumbai, probably I would be the first one to add azithromycin. But with my epidemiology in Delhi, I may be thinking twice before penning down azithromycin than this child, and wait
So
for maybe a day, two more.
would you continue the amoxiclav that the pediatrician has
No,
started?
I would not even consider amoxiclav in this child.
No, he's already on amoxiclav. I told you that he came with 48 hours of.
But that's a very difficult answer. I would probably stop it.
You would
I
stop
would probably stop it. And
Quick.
these children, I cannot be quoted on this. I have no objective proof for this. These children actually improve with a short-term with the inhaled corticosteroids. My personal experience, I am not vouching for it. I am not giving you an objectivity to it.
So a quick yes or no for azithromycin from Sham and Bala.
Vijay.
Yeah.
If this child, 10-year-old, is having wheeze and crackles and is not hypoxic, not very toxic, why should I do anything other than symptomatic management? And probably if there is history of wheeze in the past and there is family history of asthma, and with the
child is running, child is febrile. Child is febrile for 5 days. Running fever.
Yeah, fever. This could well be a viral LRA triggering. This could be anything. And
so you would not use azithromycin.
This is not, there is no hypoxia. So child is not very severely ill. Like I said earlier, this child, 10-year-old who's mildly symptomatic, is not going to be helped by azithromycin, even if it is in mycoplasma. Unless the child is severely ill, I'm not going to do testing or even treating. And decision of amoxiclav with a CRP like this, I don't know the fever, whether it is low grade or high grade, wheeze is there. Probably I would even stop amoxiclav, give salbutamol, consider prednisolone, 1 or 2 milligram per kg, give nebulized salbutamol and observe the child for a day. Because 10-year-old child is not going to crash with staphylococcal pneumonia with an X-ray and a clinical picture like this. I wouldn't be too worried.
Dr. Bala, my 10-year-old child fever going on for...
1 minute. The point is, again, I'm repeating this. There is no data in literature to say that in such cases, case 1 and case 2, minimally symptomatic children with suspected mycoplasma, your treatment does not alter the course of events. So don't worry too much about mycoplasma in mildly symptomatic children. That's my take. And if you keep on testing all these children, definitely, yes, mycoplasma positivity will emerge. And we don't know whether that positivity of IgM as well as PCR, whether it is true positivity or recent infection, don't know. So in such a situation, mildly symptomatic children, I'm sorry to repeat this, it is holistic clinical judgment rather than laboratory testing and empirical antibiotics.
So okay, just to reiterate, the first case,
my take is, see, I think the confusing part is the wheeze. And I don't know the past history, the child is a wheezer.
Correct.
So we know if the child is a wheezer, is likely to have some craft sometimes on one side. But if the whole history is 5 days fever, and he is having just crepitations on the left side, and there's no wheeze, and the fever is continuing, and the child is having little constitutional symptoms, I'll definitely consider mycoplasma. But in this case, when the wheeze is there, I'm more inclined towards maybe this is an allergic patient, maybe reactive airway disease. And that I agree with Bala that I'll be putting on basically treatment for RAD and watch for next 24 to 48 hours. Maybe it is a viral triggered. But the classical thing which happens, which I have seen in good number of cases, is only crepitations, no wheezing, nothing.
So let me complete this story. First of all, the first child that I showed you was not Mycoplasma. That was a prototype case
Classically
that I
viral.
wanted to bring up to
Classically
say
viral.
that we should not use as it.
And age
But
3
this
years.
child, 5 days, 101, 102 fever, not very sick looking, but at the same time having crepitations on the left side, wheezing. He's been occasionally wheezing in the past. I started this child on azithromycin, making a clinical diagnosis of Mycoplasma because there's a lot of mycoplasma we are seeing, and I got his mycoplasma done also, and he became afebrile 3 days after starting, and his mycoplasma IgM was more than 27. This was done on day 8 of his illness. Anyway, let's move on to now. Let's address these questions. So we have almost said when to treat with azithromycin that Dr. Sharma has beautifully alluded to. When to test, what to test, blood, nasopharyngeal swab, or other test, or what test? Do you do serology or do PCR on nasopharyngeal sample? If I say PCR, the sample that is easily available is nasopharyngeal. And Dr. Bala showed us that article where 20% of asymptomatic children also carried mycoplasma in the nasopharynx. So if I have a good pretest probability in an outbreak kind of a setting where you have a school-going child who is not very sick looking but clinically looks like pneumonia, should I subject such a child to nasopharyngeal PCR? Or at the end, after a week or so, should I do serology and do IgM? What practice do you follow?
So let me give you a.
Oh, sorry.
Can I?
Chitkara, you go.
Yeah,
Can I
Chitkara,
take?
chalo.
Okay, so
Yeah.
I am going to take diagnostics of mycoplasma in 2 minutes.
Yeah.
Number 1, remember CBC, CRP have no value at all. No point, even if you suspect mycoplasma, doing cold agglutinin. That's very non-specific. Now the question is, like Bala asked, is there a gold standard? There is actually a no gold standard. And if you consider what is a gold standard, it is 2 things simultaneously. 1, detecting mycoplasma in your PCR, preferably in an induced sputum or in a sick patient, a mini ball. Remember, with a confirming serology, which will be positive only in second week. So 2 together would probably be the first gold standard. Either of these respiratory PCR vis-a-vis mycoplasma serology are really not diagnostic. The second gold standard, or I will call silver standard, is if you document in a paired sera rising IgG or IgM. That is a silver standard, I would say. But then after recovery, no one would allow you to take a blood sample. So that is a limitation. And then individually, they have no concordance. If you see all these studies which are there from India, and whatever studies I'm quoting, I'm only quoting Indian context, not European or American. There has been no concordance in respiratory PCR with various PCRs, whether it is a conventional PCR or a nested PCR or an RT-PCR or a real-time PCR. There is no concordance between PCR vis-a-vis serology. And remember, mycoplasma is a ubiquitous organism. We have all faced mycoplasma in and out. We might be asymptomatic, mount an immune response, which will persist for months. IgM persists for anything about 3 months. IgG persists for a longer time. So a paired rise is the second option. And then third may be a clinical correlation with either a positive PCR, especially from a lower respiratory tract, or a positive serology if you are late in the disease, let's say second week. So that's about concisely about the diagnostics of this. About
so
the
Chitkara,
swab.
points.
So just one liner about a swab. Preferably to take a throat swab rather than the nasopharyngeal swab. You just swab that over the tonsillar area and probably the posterior pharyngeal wall. Nasopharynx invariably sees in and out of various bugs, And that is where we have gone wrong with our upper respiratory PCRs.
Okay, so points are well taken that IgM can, it comes positive only second week, can remain positive even for 8-9 months, Chitkara,
Yeah.
for that matter. And so, but my question is, if you have a clinically fitting picture of mycoplasma and the patient is to be treated on outpatient basis, would you empirically treat this patient or try and establish the diagnosis? That is my question.
The crux is, I think it is something similar to what you do with strep throat. I give you an example. You have a viral type picture of a URI, and you start doing first step test, and it comes positive, and you say step test is positive, so I have to give amoxicillin for 10 days. But actually, it is a nasopharyngeal carriage of strep. So if there's an absence of viral, only then you will start thinking in terms of step test. So in this case, I think first of all, it is very important to have a clinical picture which is fitting into sort of a mycoplasma. Otherwise, IgM can be false positive. Even your PCR can be false positive. Dr. Bala showed you the data that the asymptomatic patient had more mycoplasma in their throat as compared to symptomatic patients. So I think no test is foolproof and there's no gold standard. So once you suspect this and when you test, in my OPD practice, if I suspect, I do not test. I just give azithromycin and that's it. And paracetamol SOS. And I tell them in 48 hours there is an improvement, continue this for 5 days. And if there's no improvement, let me know after 48 hours because I expect a response in 48 to 72 hours. So
I take, Sam, I take your point that presence would not necessarily mean a disease.
Dr. Bala wants to
Bala.
add something.
I think we should give a clear message to the audience. One, testing as outpatient should never be done for mycoplasma. I am sure all the others would agree with me.
Yes.
Agreed or not?
Yes, absolutely.
I think that's a message which I think we should give to the audience, because what is going to happen is that now that we are talking about mycoplasma outbreak, people are going to start for the next outpatient case with LRI, V's. They are going to ask for IgM or PCR, which should be discouraged. That is one. That is one. Second, you should consider, on the other hand, you should always consider doing a test if you are going to start treating with azithromycin or doxycycline or levofloxacin on a clinical diagnosis of mycoplasma. Agreed?
Yes.
On a diagnosis. 2. 3. No test has 100% specificity and sensitivity like our blood culture for salmonella, typhoid, for mycoplasma. 4. If a child has a compatible clinical picture consistent with mycoplasma pneumonia, I'm repeating it, clinical picture compatible with the diagnosis of mycoplasma pneumonia, if PCR and or IgM are positive, your chances of correct diagnosis are very high. On the other hand, if the pre-test probability is very low, you may end up having lot of false positive IgM as well as PCR. PCR from a sterile fluid like pleura or CSF, or if you happen to have pericardial fluid or peritoneal fluid or joint fluid, yes, that should prove mycoplasma. PCR from nasopharyngeal aspirate or throat swab may be a commensal or may indicate. And finally, if your patient is ill with a clinical picture of mycoplasma, and if any of the test is positive, including cold agglutinin test, which has got 50% positive sensitivity and specificity, you should treat in a severely ill patient. And last, most Puritans quote in literature that if you have a combination of PCR positivity, even from a nasopharyngeal swab or a throat swab, and if you happen to have a paired sera of IgG, not IgM, IgG, taken 4 weeks apart, this combination is considered as confirmatory. And finally, today in China, they do only PCR and genetic testing for sensitivity from the samples, and then they report 91% resistance to azithromycin. In Japan, it's to the tune of 80%. These are all based on molecular tests. And 16 as RNA or 18 as RNA would, I'm sure, which help us diagnose more and more mycoplasma in future with also azithromycin resistance or sensitivity. These are my comments. Thank you.
So all experts' points are absolutely well taken. Empirically on outpatient basis, won't treat. But I would tell you one example where I had in fact, the first test that I did this season, a 9-year-old child who had fever for about 12 days, high fever, would cough incessantly, had crepitations, X-ray done showed a lobar pneumonia patch. And the child had what is typically called as walking pneumonia. I did IgM and it was strongly positive, and that helped me treat this child only with azithromycin. I did not use any other beta-lactam antibiotic. These are such exceptional occasional cases where it helps, it makes you confident. I agree. I take your point that in mycoplasma, the outcome, there is a school of thought that you need not treat also. Eventually they settle. But it definitely helped me not use a beta-lactam in that child. Anyway, let's move on to this second case. This is seen on day 3 of fever and cough. Prescribed salbutamol and paracetamol. On day 7 of fever, cough increased. Child is active, again crepitations, counts marginally high, CRP 24. This is what the X-ray is. Now, this is again a very common scenario, and the purpose of bringing out this discussion today is to caution all the pediatricians not to use antibiotics left, right, center. So if you have these options, use empiric azithromycin, do X-ray test and use azithromycin, do mycoplasma and IgM and then use azithromycin, use amoxicillin plus azithromycin, or only amoxicillin, or amoxiclav. So these are the questions and these are the options which are available today to treating pediatricians. So I want you to comment quickly on how should a pediatrician go about. We have already talked about when to suspect, what to do, but this is what a pediatrician is facing today. So what decision will you make in such patient? We agreed that we will not test, but here you have a child who is having persistent fever of 7 days, and the fever has increased, cough has increased.
Why not give only amoxicillin? What's wrong with giving only amoxicillin? 3 days fever, cough, no hypoxia.
No, Dr. Bala, the fever has persisted. He's crossed 1 week.
You have put only 3 days. Oh,
7 days of fever. 7 days fever.
Yeah, this child, 7 days fever with cough. See, even if there are crepitations, 7 days fever, I don't know whether spleen is palpable or not. In this child, I will definitely do no. No, I wouldn't, if there is no respiratory distress, no hypoxia, I wouldn't do an X-ray. I'll do a complete blood count and do a blood culture. Consider the possibility of enteric fever in this child. 7 days fever, 7-year-old child, fever, cough, enteric fever can present as bronchitis and go on. I will definitely do a blood culture, look for splenomegaly, consider that. Or if the child is very stable, I would only give amoxicillin, not give any azithromycin at all for this patient who is outpatient. Again, no hypoxia, no wheeze, no respiratory distress. I wouldn't be considering azithromycin at all for this patient.
Dr. Bala, a direct question for you. 1 minute, Dr. Bala, a direct question for you.
Yeah.
With 7 days fever, some crepitations, with this kind of, you wanted some counts and CRP, it is already there. Do you think it is a... 1 minute. Do you think it is a bacterial infection other than mycoplasma? Number 1. And number 2, if you decide on antibiotics, why not azithromycin alone? Why do I need to use beta-lactam in this patient?
Yeah, see, that's a very good question. Very good question. In fact, in the IDSA guidelines, for anybody who has pneumonia above 5 years, using only macrolide is not an incorrect choice. Is not an incorrect choice on clinical grounds. Here again, if you are very sure you are not dealing with a typical pneumonia, child is not toxic, and if you are considering mycoplasma pneumonia, no hypoxia, no severe symptoms, considering azithromycin is not criminal in this patient who is 7-year-old. But you are not dealing with a bacteremic pneumonia in this child, obviously, in somebody who is 7 years old. So you won't go wrong if you use only azithromycin if you are considering mycoplasma on clinical grounds. I agreed with you.
Vijay,
This
what is
shall
the degree
neither
of fever
clinically
in this patient? Vijay, what is the degree
101.
of fever?
101.
Throughout.
Yeah.
I think for fever
And
which
did
is
not look
going
sick.
on,
Did not look sick.
a
Walking
fever which
pneumonia.
is going on for 7 days and there's a cough, left posteriorly crepitations, and the counts showing neutrophil is just 32%. I'll put my money on basically a respiratory infection and most possibly mycoplasma in this case. I won't consider enteric fever in this case.
Absolutely.
And I'm quite okay with giving only azithromycin.
So I treated this child only with azithromycin. Okay, let's move on to the next.
Vijay, the point is, above 5 years, giving azithromycin is not irrational alone. Below 5 years, giving azithromycin alone on a clinical basis is irrational. That's the important point we have to send home to the audience.
Okay, he was also
Sir,
mycoplasma strongly positive.
sir, Dr. Bala, with due respect, even below 5 years, with this kind of an symptomatology, and
one would,
when I have showed you a literature that it is equally common even in below 5 years. We are going by a conventional wisdom of earlier 2000s when we thought it was only of 5 years and above, when the statistics indicate something different. So therefore, even in under 5 years, I do expect it is not going to be by any stretch of imagination natural influenza, strep pneumonia, or a staph. So I would probably err more in favor of an azithromycin, even in children below 5 years with this kind of a presentation, rather than sticking to my CAP guidelines of only beta-lactam.
But Chitkara, but below 3 years, at least there is enough evidence. In fact, I can quote the BTS guidelines which say that below 3 years, using macrolide alone is irrational.
alone is not. So you would use a combination of beta-lactam plus macrolide.
Yes.
If at all you say. Yeah, fine. So look at this child. This child came from outside, fever for 3 days, high-grade fever, cough, but child wasn't sick. He had mild wheezing. This child had undergone this test outside, CBC, CRP, blood culture, and X-ray test was done. So how would you, I mean, the results were not available. The child came to our hospital. So what antibiotic would you put this child on? Anyway, this was the X-ray, and we started this child on a beta-lactam antibiotic. He was started on a macrolide also because he didn't look typically sick of a typical pneumonia. And you see a definite consolidation in the right lower zone. So this child was started on coamoxiclav and azithromycin. These were his counts to begin with, 11,000 counts and a very high CRP. The fever persisted. And this was the pattern. So since the fever persisted, he came to us on 25th. 2 days later, the fever persisted. We started getting impatient. The patient insisted on repeating an X-ray. So this was a repeat X-ray. Now, if you look at these two X-rays, I mean, there was again a difference of opinion. I believe that there is always a lag or discordance between clinical findings and image becoming more dense or clearing up. So to me, this did not look like worsening picture, but my colleague felt that it was worsening. And on the background of this persistent fever, we got a sonography done and which showed minimal pleural fluid. And the counts which were repeated, not the pleural fluid, I'm talking about peripheral blood count. The WBC had come down to 7,000. CRP also had started coming down. So he had inflammation because of the pneumonic effusion, perhaps. The fever persisted, and there was a lot of anxiety, and thinking that this could be a non-responding pneumococcal pneumonia. So vancomycin was added. With 1 dose of vancomycin, this child developed allergy. This vancomycin was withheld. The child was started on linezolid. We had a huge difference of opinion on this, but linezolid was started on this child. And 3 days later, this is the X-ray. Finally, the child became afebrile and the child had mycoplasma IgM of more than 27. So this child was treated with 2 antibiotics, a beta-lactam and a macrolide, had very high inflammatory reactants, acute phase reactant of CRP 119, had symptomatic effusion which was non-tappable. The counts did not rise very high. CRP settled over a period of time, was treated as a non-responding pneumonia, perhaps a non-responding pneumococcal pneumonia, and was hurriedly started on vancomycin. He developed allergy, so was changed to linezolid. But the mycoplasma IgM was more than 27. Finally, we discharged this child. A few questions remained unanswered in this question, and I want answers from you experts. Was it a delayed effervescence because of immune-mediated phenomena associated with mycoplasma, or was it because of the associated symptomatic effusion, or was there a co-infection with pneumococcus? And was it intermediate resistant strep pneumonia? And could you have waited without adding vanco or linezolid? These are the questions that I want you to take.
Vijay, coming to delayed effervescence. In fact, I don't know. I have not seen what do you call the so-called refractory mycoplasma pneumonia. That's what is described in the Chinese literature. In the Chinese literature, in fact, I recently came across an article where there was a consensus meeting in China on difficult mycoplasma. It's there in the net, where they define two things. One is mycoplasma pneumonia, which is resistant. The other is inflammatory response in mycoplasma pneumonia. Both are described. How you diagnose these two? One, in China, what they do is do a PCR and prove the drug resistance. One. Two, for diagnosis of inflammatory syndrome in mycoplasma, in the Chinese literature, ferritin as well as LDH and CRP are mentioned as very important clues. In fact, Chinese literature suggests that if you have a CRP more than 40 in mycoplasma, you always think of hyperinflammatory syndrome. On a similar note, elevated ferritin, significantly elevated ferritin and LDH, the patient is not responding. In China, they consider two things. One is steroid, the other is IVIG. But unfortunately, in China, they have facilities to do PCR and drug resistance and get the immediate report. In this patient, even though the X-ray looks like there is some significant fluid, like we attempted in our case, I think I would definitely attempt a minimal. I would attempt a tap and try to get the fluid. And from the fluid, if I get mycoplasma, I can be sure it is 100% mycoplasma. It's a sterile space. And if azithromycin had not worked, I might have thought of an alternative drug. On a similar note, this is not likely to be staphylococcal pneumonia because, you have given only earlier amoxiclav. It's not likely to be MRSA pneumonia. And later, of course, you have added linezolid. And adding vancomycin perhaps might be overkill in a patient who's not bacteremic. I would have perhaps considered clindamycin and ceftriaxone for this pneumonia. And if it doesn't respond, but the possibilities of your macrolide failing would make you consider giving doxycycline. Last question is regarding co-infection. There are enough reports, not from India, but from, again, China and Japan, of co-infection with pneumococcus as well as mycoplasma. That is well reported. But regarding use of steroids and IVIG, there is very little pediatric data except from China.
Before Sham and Chitkara come in, my comments on Dr. Bala's comments. One thing is we should be a little cautious before we talk about refractory mycoplasma and macrolide resistance. Now, this child, for that matter, though apart from fever, the child did not look very toxic, number one. Number two, his mnemonic effusion, the pleural inflammation, wasn't it a good reason to have a very high CRP? And why are we thinking in terms of macular resistance here? Secondly, co-infection is very difficult to prove. So this could have been a co-infection, pneumococcus plus mycoplasma, or a plain pneumococcal pneumonia with syn mnemonic effusion, which takes time to resolve. So that possibility is there. So even with plain co-amoxiclav, with the passage of time, perhaps the child could have improved. So the point that I'm trying to make again and again, let's be a little cautious before we talk about refractory mycoplasma and jump to giving doxycycline or levofloxacin. This is what my take was. There was a difference of opinion. I thought of withholding it, but then we, in the looking at the anxiety and the tensions which were running very high in the family, we did add linezolid to this child, and child ultimately went home. His mycoplasma was positive. So my opinion is this child had mycoplasma pneumonia, perhaps an associated pneumococcal also, and the inflammation and the delay in response was because of the pleural
I think
effusion.
Vijay,
Shyam.
to start with, I think it's quite okay to give ceftriaxone. I think you started, that's right?
Co-amoxiclav. He started co-amoxiclav.
It's okay.
Yeah.
You started beta-lactam. And if the patient is, in this patient, I think it was not very sick looking, whatever history I could gather. It's not a very sick looking child. So in this patient with high CRP, high counts, you're justified to start co-amoxiclav. I think I'm quite okay with the amoxiclav, only amoxicillin. I'm quite
and
okay.
Azithromycin also.
And after that, if I feel the patient is not responding, to be honest, in my practice, whenever we have a sicker patients in our practice and admitted patients, I do not give azithromycin, I give doxycycline. I'm honest with this. But in my OPD practice, I always use azithromycin.
So, Shyam, what is the evidence to say that these children have
evidence is, and I won't say I have a very hard evidence because there's no data in my country. But I always believe if in China it is 90% resistance,
there's no reason why it should
I have seen one case where I was telling Dr. Bala that I presented in his hospital. It was a resistant case and the child was not responding to azithromycin. So I think you carry that baggage and you feel one of the patient didn't improve and you start on doxycycline. And it's not something like, I think, doing a very high-end antibiotic. And that's quite okay. So I admitted sick patients.
I think
Shyam,
Vijay,
I would have used ceftriaxone with clindamycin to take care of necrotizing pneumonia and added azithromycin. Ceftriaxone with clindamycin to cover.
Necrotizing ke liye sick nahi
Why
hai,
would you think of a sick looking, not sick looking child necrotizing pneumonia?
This child has got a pleural effusion and pneumonia. Definitely, I would have non-responding pneumonia. One of my diagnostic possibilities is a necrotizing pneumonia.
Necrotizing children are very sick. Bala, because this child wasn't very sick.
Need not be sick. Non-responding pneumonia, I'm going to think of necrotizing pneumonia, and I would have
so may I?
Yeah, please.
Sure.
Yeah. So there are two questions raised on this case. Number one, was there a need to add Vanco or Linezol or a kind of an anti-staph medication? See, invariably, staph pneumonias, they make the child very sick in the first 2, 3, 4 days. The staph never waits for 7 to 10 days to make the child sick. And at the same time, you tell us this child was not very sick.
Chitkara DRSP. Forget staph.
Yeah, so,
about DRSP.
So therefore, DRSP. Now, if it was a DRSP, probably this child would have deteriorated. And this was a kind of a syn mnemonic effusion, which was a minimal effusion. And at the same time, in the second week, or maybe 7, it was already 7 days when the child was on amoxiclav, and you gave us a serology which was IgM 27 positive. So therefore, I do not refute an idea of adding an azithromycin in this child, rather than consider, because DRSP or a strep pneumonia, if they were resistant and they were not amenable to co-amoxicillin, this child would have deteriorated very fast rather than stay stable except for that persistent shadows. And we don't chase shadows in X-ray chest over a period of 3 days, every third day or a fourth day. and which has not been increasing, except that there was an evidence of a minimal effusion. The second question you raised in this case was, if it was a mycoplasma, is azithromycin good enough? Sham said there is no data. I refer to Bala, your study from ICH, very good study. I am yet to come across any resistance studies in mycoplasma on 350 samples, where every damn possible gene conferring resistance to macrolide was studied in that. And this is from, I think, Perumal, from Institute of Basic Sciences in Chennai. You might be aware.
Taramani.
Yeah. So every possible gene they had, which is invariably what we call as a P1 or P2 adenosine and 23S ribosomal fraction. And not even a single resistant gene was found in a 350 samples which were mycoplasma positive. So therefore, I have reasons to believe that our mycoplasma in India probably retains susceptibility to azithromycin. So if we keep on discussing using of alternative drugs like a doxycycline or maybe newer fluoroquinolones like levo or moxifloxacin, probably it will be too premature. And this study was published in 2023. So not very old study, and the data was till 22, from 19 to 22. So therefore, we have reasons to believe on the strength of this study that at the moment, it is a conjecture to believe that our mycoplasma is resistant just because Chinese or Japanese. Japan has been saying resistant 90% 10 years from now. China has declared resistance in the last 3-4 years. After that, December 23, their mystery disease happened in northern province. So as far as Indian context is concerned, let us not be misled by these Chinese and Japanese report. Yet at the same time, we should be on an outlook for development of azithromycin resistance because it is one of the very misused drugs in India. Okay.
Absolutely well made. So my take on this case was this was probably a mycoplasma pneumonia with associated pneumonic effusion. That was one of the reasons why he responded late. And I take your point that we do not have a solid evidence of resistance, but at the same time, as Sham said, if it can be to the tune of 90%, 80% China and Japan, there is no reason why it cannot come to
So
India.
I'm
So we
using in
need to
sicker
be a little
patient.
more
I'm using in sicker
vigilant and
patient.
vigilant. Okay. This is fever for 7 days on a regular Weezer, normal counts. IgM done on day 4 was negative. Somebody, because mycoplasma, now everybody has started thinking of mycoplasma. It was negative initially. I think I will skip this case because we have. Okay, now this is a 9-year-old child. Fever for 6 days and cough. Taken augmentin ES for 5 days outside. And he's afebrile for last 4 days now. His counts are normal. He comes with left ear pain. And this is what the otoscopy reveals. He has normal eardrum on one side and the other eardrum is inflamed. There is no bulge like a typical otitis media. But you can see some fluid behind the eardrum. Now, my question is, how common is otitis media with mycoplasma? We know that it can occur. Bullous meningitis is known with mycoplasma. And this child who has a 9-year-old child with unilateral ear pain, who has received amoxicillin high dose for 5 days, today is afebrile but has left earache with these findings. Would you consider giving him azithromycin?
ये थोड़ा सा difficult question है. I gave you statistics. See, once we are preoccupied or we have a fixed mindset of seeing more mycoplasma, we attribute everything to mycoplasma. Like I gave you a statistics that I had 34 x-rays done and 11 of them also had otitis media. And these 11 otitis media received only beta-lactams, amoxicillin, and they improved. None of them required azithromycin. So therefore, let's go. While see, mycoplasma can cause otitis media, there is no doubt about it. Any part of the body can be involved with mycoplasma. which will be immune mediated. However, this could be a direct infection. But let us not go overboard with thinking that there is any specific finding in tympanic membrane which is specific to otitis media. So there to mycoplasma. So therefore, I still think if you have otitis media and you decide to treat in a particular child, I would still go in favor of a co-amoxiclav rather than risking with azithromycin, because evidence cannot really be certain unless I do middle ear fluid and detect mycoplasma in that. Even if that is there, I am not very certain that was only Mycoplasma otitis media. Okay.
In other words,
Christoph, just a minute. Christoph, your reasoning and rationale is absolutely well understood. Here you have a 9-year-old child, unilateral otitis media you would not treat, and he has already received 5 days of amoxiclav. So one would leave him alone or use azithromycin. These are only 2 options.
Vijay,
Yeah.
very simple answer. Bullous meningitis is commonly caused by pneumococcus and not mycoplasma. I can give you literature evidence.
Fine.
Let me complete. Bullous meningitis is not synonymous with mycoplasma. 1. 2. Here, this child has got otitis media, but there is no fever now. There is no fever now. There is only otitis media. This child, I would ask the ENT surgeon to do a myringotomy and clear this bullous meningitis rather than start azithromycin to cover mycoplasma. Third, again, like uncomplicated lower respiratory infections, there is no evidence in literature that azithromycin makes any difference to anybody with bullous meningitis due to mycoplasma. So I wouldn't be worried. This child who, in spite of augmentin ES 5 days, has got bullous meningitis, I would definitely take an ENT help and perhaps assess the audiometry, etc. And I wouldn't handle this child with and I wouldn't give azithromycin. You already said there is no fever. Why should I worry?
I have a different take.
Two questions. Is this Sham? First, is this bullous meningitis? I don't think this is bullous meningitis. Number 1. Number 2, in an afebrile child, why would I ask him to go to ENT and do myringotomy? Why not leave him alone? Or at the most, on the background of this outbreak and this kind of X-ray picture, at the most azithromycin.
I wouldn't give azithromycin to this patient. That's what I'm coming to. Because
okay, Sham, you have a different take.
Most cases of
slide में ना caused by pneumococcus, not by mycoplasma.
नीचे वाली स्लाइड में ना मुझे बुल्लस लगता है. I don't know. ये नीचे वाली स्लाइड.
This is bullous.
ये बुल्लस लग रहा है. Is it
okay?
So if it is,
but this is a true picture. Yeah.
If it
I
is
don't know whether to
bullous,
call it bullous or what.
It is a bullous, even if it is unilateral. See, now coming to the etiology, I agree with Dr. Bala. I think we have carrying the baggage of literature, because earlier it was believed that bullous meningitis is classically a sign of mycoplasma. Now, a lot of data is available which indicates still the commonest cause is strep pneumoniae. Other bacteria can also be involved. It is not very specific, as Dr. Chitkara was saying, for mycoplasma. It is something like a theory which Dr. Ron Dagan gives. The pathophysiology is such, whenever there is a otitis media, whatever is there in the throat is sucked into the ear canal and into the eardrum, up to the eardrum. So it is possible because mycoplasma was there in such cases, but it is basically the strep pneumoniae which is causing the disease. So the literature says if this is really bullous meningitis, in that situation, if it ruptures, there's always a very hemorrhagic discharge. So in such patients, you must treat this strep pneumoniae. And if it is not bullous, and if the patient is not febrile, I'll classically wait and watch the policy. But if it is bullous, I will treat because of risk of hemorrhagic discharge.
So all points very well taken. This child had already received good antibiotic for 5 days, and this is what he came with. He being a 9-year-old child, afebrile, unilateral earache, we thought of leaving him alone. His mycoplasma was, by the way, more than 27. And this was his Excel picture also.
Vijay, 1 minute.
Yeah.
All your mycoplasmas
are
all your mycoplasma serologies are stuck at 27. I do not know why. Number 1.
More than 27.
Number two,
More than
number
27.
two,
More than
number
27.
okay.
More
So
than that lab does
okay,
not.
okay.
Yeah.
So number two, if you see these images of the tympanic membrane, acute otitis media, which is active and has developed, the tympanic membranes are angry looking red, with or without a bulla. These two images, in the upper image, there is hardly any vascular congestion, while the lower indicates some kind of a congestion. And a 9-year-old child, and whenever we decide to treat otitis media, we must treat it for at least 10 days. So this child is on 5 days of augmentin ES. If the symptoms have improved, the child is not very sick, this ES or whatever augmentin you are giving or amoxiclav should have been continued for 10 days without any interference. Now, use of azithromycin can only be possible if I stay in Mumbai, I think of mycoplasma, I eat mycoplasma, and I sleep mycoplasma. Then azithromycin is indicated.
So Chitkara, I'm not proposing that
Vijay,
such
even
children
then
should be treated with,
azithromycin
but
is
this
not
I'm,
needed.
I'm,
Even
I'm
then.
nahi de. What I'm trying to, so I'm not proposing that otitis media should be treated with azithromycin. What I'm trying to say is, but I beg to differ that a 9-year-old child with unilateral otitis media give augmentin for 10 days. No, that's not the recommendation. No, you don't
Vijay,
continue antibiotic
Vijay.
for 10 days in a 9-year-old child.
Vijay, this is not
Yeah,
mycoplasma otitis media. It is mycoplasma antibody
accepted.
positive syndrome.
So neither,
If it's
but
antibody
I never,
positive syndrome, it doesn't mean anything to me.
I never,
It's a
Dr.
waste
Bala,
of
I never
money to
said
do.
that this.
It is a waste of money to do IgM antibody for this patient.
I never said that this was Mycoplasma otitis media. I showed you the facts, and I told you that this is a school-age child with fever going on for quite some time, and his mycoplasma was positive. He might have had, but I'm not saying that this was
Vijay, the
Mycoplasma otitis
audience will
media.
take home a message
No,
saying
no. That's
that you
the
have
reason.
IgM
Okay,
for such cases. Please.
I'll show you more interesting patient. This
I
is
think
another
Vijay,
9-year-old child.
after this case, the message is, if it is bullous, please treat, even if it is unilateral.
Streptococcus. Yeah, because next
And
case
treat
will clarify.
streptococcus and not the mycoplasma.
Absolutely. Sham, next case will
If
clarify
it is
that.
unilateral otitis media, which is not bullous, please don't treat. Wait and
Please
watch
don't
first.
treat. Yeah.
Wait and watch first.
Next case will clarify. Absolutely. I don't disagree at all. Now, next case will clarify everything. This is a 9-year-old child, again, fever and cough for 4 days. His SIB had multi-drug resistant cervical lymphadenopathy, TB, 2 years ago. Treated successfully at JJ Hospital. This child was treated with coamoxiclav and ciprofloxacin by someone outside for this shadow. Now, these parents were a bit worried about tuberculosis because they had gone through a hell treating the older SIB, 2 years of ATT. And on their insistence, the pediatrician got a CT chest done. And this is what the CT chest showed. And this child was afebrile for a week after a course of coamoxiclav and ciprofloxacin. This was an outside story. And he came to me on 25th November, left ear pain and cough. No fever. He had only earache. And the tympanic membrane was mildly congested on the left side. Right tympanic membrane was normal. This child, looking at the X-ray picture and the outbreak, was treated with azithromycin. Now the story is, this is what the CT had showed. Multifocal peribronchial consolidation with surrounding ground glass opacities on the right upper lobe, right middle lobe, and the right lower lobe of the lung. Features suggestive of infective etiology. Now this child, I sent him home on azithromycin, not for ear infection, but for this respiratory tract infection. And with the outbreak that we are seeing here, 3-4 days later, this child became sick, went to a pediatrician locally. He repeated because he had fever and cough. The repeat counts were 30,000 with 87% neutrophils. Child became breathless, came back to us, got hospitalized. And this is the repeat otoscopy, which was done on the day he got hospitalized. Now, today, after say 4 or 5 days, it began with respiratory infection treated with coamoxiclav and ciprofloxacin. He was afebrile. A week later, he developed ear pain. One side ear normal, second side had little congestion. Was sent home. Was given azithromycin not for ear but for the respiratory tract infection. Continued to develop fever worsen, earache worsen, cough worsen. Repeat count 30,000. Child started looking sick. He became breathless. He was referred back to us. This was his X-ray on 30th November when he got admitted. And these are his bilateral ear findings. This child was admitted, was put on HHFNC, injectable ceftriaxone, and azithromycin he had completed for 5 days, was continued for another 2 days. His counts, when we repeated 24 hours post-admission, had come down to 15,000. His CRP was very high, 162. And his blood culture gave gram-positive cocci. And the child being very sick on HHFNC, he was started on vancomycin. His mycoplasma was strongly positive. And now I want to ask you whether it is casual or causal. Was it a co-infection with, because this pathogen which was identified was strep pneumonia, which was intermediate resistant with MIC of 0.12. And we treated this child with injectable ceftriaxone. Once we got this report, we withheld vancomycin. Because ceftriaxone with 0.12 MIC could be treated. But we discharged this child on high dose amoxicillin, only amoxicillin. And this is a repeat otoscopy after successful treatment with high dose amoxicillin. Now the question remains whether it was what happened? This child had probably this streptococcus pneumoniae, which was partially treated with coamoxicillin and fluoroquinolone. I gave azithromycin because when I saw the child was afebrile but had this kind of an X-ray picture. Earache with an afebrile period in between, which worsened, respiratory tract infection worsened, and this child had bacteremic pneumonia with streptococcus pneumonia, which was intermediate resistance. So this is what I wanted to show, and this is what, so co-infections are not uncommon. So, the only evidence to say that it was co-infection, we definitely had culture-proven evidence of culture to say that it was streptococcal infection. Given the background outbreak and the age of the child and the picture which lingered on and a positive mycoplasma serology, I can at the most say that it was co-infection. I want you to comment on this.
Very simple. IgM positivity can occur in 10% of population. In fact, we have data from our own institution where a PG thesis was done. 10% of normal children have IgM positivity with such high titers. It's not uncommon. IgM positivity does not confirm diagnosis. It's no more taken as confirmatory evidence of mycoplasma pneumonia. In this child who was
point well taken, but a clinical corroboration.
No. Clinically, you have
test probability.
You have microbiological proof for streptococcus pneumonia. Why should I wouldn't be testing.
This is the second phase when he deteriorated. This is the second phase when he deteriorated. First phase he had patch. He was afebrile. That is the time he was started on azithromycin.
When you have grown pneumococcus, IgM positivity
undisputed. Yes.
Cannot make you diagnose mycoplasma pneumonia. So it is
fair enough.
Pneumococcal pneumonia. That's all I will say. Even the otitis.
Only it was pneumococcal
pneumonia.
That's fine.
And we also discussed that IgM positivity may stay for months after asymptomatic or even subclinical infections with mycoplasma. So therefore, that is not a gold standard. So this is actually a strep pneumonia issue which was adequately treated.
Vijay, this is very classical of pneumococcal pneumonia. You have high counts, you have lobar pneumonia, which was partially treated earlier, which confused you. And once the treatment was stopped, he worsened. And this is classical pneumococcal pneumonia and well treated.
Okay. The other reason for showing this case was this was a third case where we have grown streptococcus pneumonia, where the MIC in non-meningeal isolate has been higher.
So had this been meningitis, you could have treated ceftriaxone with vancomycin.
Meningitis, we know the cutoff. Anything more than 0.06 is taken as resistance. But non-meningeal, we think that non-meningeal isolates in our country are still sensitive.
Absolutely.
So
So
I'm
this
not
was
proposing
intermediate,
anything.
and this was
But
intermediate,
but
and you could
but
obviously
but
treat it with
but at the
ceftriaxone.
same time, at the same, like Mycoplasma, we need to be on lookout for perhaps increasing resistance in non-meningeal isolates in strep pneumonia in our country. We should keep our minds and eyes open to that. Okay, let me see if I have. Okay, now this is an interesting question. This is a 9-year-old girl, fever and cough for 4 days, low count, normal CRP, has received amoxicillin 125 BID for 5 days, a 9-year-old girl child. 5 days later, the cough persists, but there is no fever. So obviously, inadequate dose of amoxicillin, a school-going child, and who responded? And this is the X-ray picture. Repeat X-ray is also done, and this is what the repeat X-ray shows. So perhaps this was Mycoplasma, which did not require any treatment. Now this child was not treated. The counts were normal. Mycoplasma IgM was done outside, it was 30, not treated with macrolide. Now, the 6-year-old SID comes with fever of 1 week and cough. Respiratory system is normal, nothing on clinical examination. Counts normal, neutrophilic counts, CRP 16. And this is the X-ray. Now, what do you call this?
Viral pneumonia.
With Mycoplasma antibody syndrome.
Don't tell me. So let's like while I'm not being Bala and Chitkara, while I'm not being biased, I'm in fact cautioning people not to use azithromycin indiscriminately. I'm saying that not to jump to conclusion that we have macular resistance. But at the same, let us not be blindfolded that there is no mycoplasma. Mycoplasma is highly contagious. Mycoplasma can, tubes. My question is, how far is the old teaching? Does it hold water that Mycoplasma, even if you prove mycoplasma, it need not be treated? That is my question.
Clarification, Vijay. Mycoplasma is not highly contagious, number one. Number two, Mycoplasma, if it was so contagious like influenza and measles, we would have had clustering in a family, which is not there. It is conventionally believed that it is not an aerosol transmission. It is a big droplet transmission. So that is why the reproductive number is not very great with Mycoplasma and really requires prolonged exposure, going by how the Mycoplasma behaves. So therefore, I would not say that it is highly contagious, but yes, close contact for a prolonged hours can lead to Mycoplasma. But it is unusual to see primary cases or index cases or secondary cases in a family where one sib or one member is affected by Mycoplasma. So that is one statement, number two. And number two, these kind of pictures where 2 or 3 family members having this kind of radiological picture, which is more suggestive of an infiltrative or a reticulonodular but not nobar, would probably suggest a viral etiology which would persist for 5 to 7 days. Whether we treat it for Mycoplasma or not is a very difficult question unless you have a local epidemiology where you are overwhelmed with Mycoplasma. And we have already discussed that there is no hard and fast rule for a diagnosis of a Mycoplasma. So it is more of a conjecture rather than giving a dogmatic proof or making blinding statements that consider Mycoplasma and treat.
My two statements in defense. One, how many viral pneumonia? They look sick. They have fever. Viral pneumonias look sick.
Why not?
These children did not look sick.
No.
Why?
Viral.
No, let me complete. Viral pneumonias look sick.
2023, adeno has been playing havoc. So-called adeno. We have been.
You mean to say this was my second statement? I don't agree that Mycoplasma is not contagious. It may not be as contagious as measles, but it is contagious.
No,
In a
not
household
as
setting, you can
contagious.
have this
Measles
second.
has a reproductive
Agreed,
number
not as
which is very high.
not as contagious.
Not that contagious.
It is not as no, it is not as contagious as measles.
Yeah,
I'm saying
okay.
that,
Right,
but
right.
you
Yeah.
cannot say that it is not contagious.
I
You
agree
cannot
with
say
you,
that it is
Vijay.
not contagious.
I agree with you, Vijay. There have been good number of family and school outbreaks due to mycoplasma. It is
Correct.
contagious. It is contagious.
Contagious.
And it is known to cause outbreaks also. Only thing is, since it has got a long incubation period, the outbreaks don't come just like that, See, similarly, simultaneously, hundreds of cases occurring is not going to happen. Cluster will occur over a period of a month or two. That is what is described in literature.
Okay, I'll move on to next case. This is a 6-year-old girl, fever for 4 days, cough for 4
ये बस
days.
करो 11 बज गए अभी
Normal counts. No, why I'm saying that I'm not proposing that you should think of mycoplasma in every case. This child had fever, cough. This is what his throat looked like. Very often we tend to forget that Streptococcus pyogenes is an important causative agent for low respiratory infection and pneumonia. So this child later on had that scarlet-in-the-form rash also, and so the point that this child was treated with amoxicillin very successfully. The point that I'm trying to make again and again is, while I agree that there should be some evidence, but let's not be absolutely blindfolded that there is no mycoplasma. There is mycoplasma in Mumbai. And at the same time, let's be very cautious. And as you all have very beautifully said, when to suspect clinically, when to test, and how challenging it is to prove or disprove mycoplasma. And disprove may be easy, but prove mycoplasma is very difficult. And not to forget that there are a lot of co-infections. We showed 3-4 cases where we give strep pneumonia in 2 cases, staphylococcus. MSSA in one of the kids with who was being treated for mycoplasma. This child had bacteremic staphylococcal infection, went on to develop empyema, required prolonged therapy. So, as Sham says, I would stop sharing here, but a word of caution that while there is clustering of cases and outbreak of mycoplasma, unlike in the past, that mycoplasma with diffuse infiltrates, no lobar consolidation, only restricted to age 5 and beyond, is no longer valid. We should be open to, be on lookout for a possible resistance, but at the same time, don't jump to calling every mycoplasma as non-responding mycoplasma as resistant mycoplasma and jump to starting doxycycline or levofloxacin, especially levofloxacin. It's an anti-TB drug which is used in our country for MDR-TB. So we need to be extremely careful. We have seen good number of cases with mycoplasma who have had lobar pneumonia, who have had effusions, and that age is no longer, limiting factor. So this is something which we have not seen in the past. And at the same time, we continue to see your regular viral pneumonias, influenza pneumonias, your strep pneumonia, your staphylococcal pneumonia, they continue to occur. But yes, there is a definite increase in case of mycoplasma in Mumbai. Over to you.
Thank you.
Thank you so much. It was very much.
I hope we did not end up confusing the audience.
That's what
No,
everybody
but I mean,
is. No, there are so many comments in the YouTube that it is.
No, I mean, Sham and Chitkar and Bala, they explained very well when to suspect. In
Just
fact, the first, Chetan, the first case, first case was not mycoplasma at all. But that is the commonest clinical symptom that all of us see in practice. And Sham has beautifully said how to tease out one from the other, when to use antibiotic, when not to use, when to test, when not to test. Chitkar and Bala both reiterated that testing is difficult, and don't get carried away by antibody positive syndrome, but at the same time keep your eyes and minds open.
Yeah, and one more comment: don't be kind of misled by expecting too many extra pulmonary symptoms, because in this particular season, with a lot of suspicion for mycoplasma pneumonia or mycoplasma chest infections, we are yet to see a surge in any of the extra pulmonary manifestations attributed to mycoplasma, though everything damn possible in the is explained by mycoplasma, but we should not go overboard diagnosing mycoplasma only when extra pulmonary sign symptoms are there. contrary to what has been the conventional teaching.
Absolutely. Cannot agree more on what
So
you're saying.
I'll just read out few of the comments from YouTube. One, this plenty of and microbiologically confirmed uh, mycoplasma in Pune. Then there was so much of confusion amongst the experts. This year, definitely, it looks like an outbreak. Doxy does the wonders. These are the comments. And the question is, any role of IV azithromycin over oral?
I think
So
what
oral
is
is enough.
oral bioavailability is excellent. You don't have to use IV azithromycin, except in a patient who's in a deep shock, in whom you're worried about absorption and poor bioavailability. That's very rare. Azithromycin is one drug which is absorbed, whether you give it in empty stomach or with food, with H2 receptor antagonist, with pantoprazole. Azithromycin is extremely well absorbed. Bioavailability excellent, serum concentrations are excellent. You don't have to worry. If you give the adequate dose, you don't have to give IV azithromycin. IV azithromycin, like cloxacillin or cefazolin, always causes a problem of a thrombophlebitis, difficult to maintain IV lines. You can use oral itself.
Also, some cardiac complication expected because we had one expiry in our area with the after IV azithromycin.
Yeah.
So rather it is, can it, suppose if you really want to go for IV, then levoflox IV should be better option if at all you want to give IV
So,
only.
so Chetan, actually there are no confusion amongst the experts, except the audience should note that there is epidemiological variability amongst different regions of the country.
Correct.
So therefore, what the spectrum is seen by us in Delhi may be different from the spectrum seen in Mumbai or spectrum seen in Tamil Nadu. We have all resorted to scientific literature which is published and as recent in last 5 years. So we are on consensus as to when suspect mycoplasma, when to treat, not to go overboard, and be dictated by the local epidemiology rather than comments from different regions across the country.
No, the panelists are like mycoplasma. Mycoplasma doesn't present the same way in every human being. Okay, there are different presentations. On a similar note, we panelists have different views, like mycoplasma. That's all. That's the beauty of this topic.
And I'm sure all of us reason reasonably well.
This is the question.
The reasons for or
Dr.
against
Aditi
everything.
Shah,
Yeah.
Dr. Aditi Shah has asked how to differentiate between if cough and eye discharge is there because of either it's adenovirus or mycoplasma.
I think if there's a eye discharge, sticky eye discharge, and cough, I will think of chlamydia.
But that will be in a younger patient, I think.
Younger also, a bigger patient can also have, but classically sticky eyes with the cough is chlamydia.
Absolutely right. The earlier belief that chlamydia is only a pathogen below 3 months has been now challenged. You have lot of chlamydia pneumonia even in older children and sometime in adults. And chlamydia and mycoplasma, and including influenza. They are reasons for congested conjunctiva, some eye discharge, respiratory sign symptoms. So there's a lot of overlap between the different bugs. But remember, chlamydia is an important pathogen even beyond 3 months, including Legionella
And
also.
I think in adenovirus, the eye is absolutely red. It is not only sticky discharge. It's
Yes,
red eye.
absolutely. Absolutely.
So,
Red eye.
but at the same time, whatever increased number of cases that we saw here in Mumbai, we did not see much of eye discharge in them.
Yes.
Okay. Is there any role of LDH or D-dimer in the early biomarkers for MRMP? What sir described, no? Mycoplasma, that term with rash and
Mycoplasma-induced rash and mucositis.
No definite data is available. No definite data. In China, what they report is a hyperinflammatory syndrome in mycoplasma, where they try doxycycline instead of after, or if they have reports saying it is if it's a macrolide resistant, they use doxycycline or levofloxacin. If still child doesn't improve, they consider this hyperinflammatory syndrome. And in China, they do give prednisolone with or without IVIG if the ferritin is high, the D dimers are high, if the CRP is more than 40, and the child is not responding. That's a protocol well described in China. But I don't know if the others have had experience. I have not had hyperinflammatory syndrome secondary to proven mycoplasma so far. I don't know with Chitkara or Sham or Vijay have come across, not seen.
Sir,
See,
first
more
of all,
importantly, more than this hyperinflammatory syndrome, the CNS syndromes caused by mycoplasma are an enigma. They are very difficult to diagnose for many reasons. One, if you have meningoencephalitis or transverse myelitis or Guillain-Barré due to mycoplasma, your PCR in the CSF may not be positive, right? You have to go only for indirect evidence like PCR positivity in the throat swab with or without IgM, right? And most cases of mycoplasma, meningoencephalitis or transverse myelitis, for which steroids and IV immunoglobulin are tried, they are all cases where the CSF shows features of aseptic meningitis with lymphocytosis and minimally elevated protein without PCR positivity. Only minority of cases of mycoplasma encephalitis, the PCR is positive. They go only by IgM or PCR positivity from the throat or from the bowel. That's the problem. It's very difficult to diagnose. In fact, I have not had experience of diagnosing mycoplasma-induced transverse myelitis or encephalitis. I don't know about others in the panel.
Well, there is a reason for it because most of the CNS manifestations are immune mediated. Of course,
you won't get
a very small percentage also have direct invasion, but that's extremely uncommon. What is commonly seen is immune mediated CNS manifestation.
Yeah, that is one
also,
Vijay, in fact, all extrapulmonary
are immune mediated.
Are immune mediated.
Absolutely.
And just a word of caution, MRMP as of now in India is a term which is not there, but yes, we are on a lookout. So all we panelists feel that MRMP is really not a problem in India as of now, but yes, a surveillance is definitely required.
Once the dermatologists start doing PCR and IgM, I'm sure they will start reporting cases.
Metagenomics will be required to prove, disprove.
Yes.
Yeah.
See, ultimately, the way forward is surveillance. We have to have our own data with metagenomics, with data on resistance, with data on good PCR proof for infection, and data on gold standard proof of diagnosis. All that is required for us to say that whatever we are dealing with is mycoplasma or not mycoplasma confidently. That's going to take some time. In fact, whatever we are seeing is definitely going to change. We are certainly going to see more and more mycoplasma. And like most other diseases, we are going to see more and more immune-mediated syndrome secondary to mycoplasma.
In this regard, there is very nice comment by Dr. M.P. Jayakrishnan that we had 4 cases of stroke, of which 3 had posterior circulation stroke in the last 1 month. All had lobar consolidation and a pleural effusion, and mycoplasma PCR was positive in throat swab and serum.
Serum positivity of
serum must be antibody.
Serum PCR plus serology both must have combined. That is the best thing.
If both are present, you can reasonably say the clinical syndrome is likely to be due to mycoplasma. That's good. That's very interesting. That's very interesting.
That's interesting, but in fact, that's very interesting. But at the same time, pneumococcal pneumonia, bacteremic, can also have vasculitic, microclots and infarcts and strokes. Yeah. So, but here in this case, both PCR and serology is positive. He should publish, in fact.
But if I consider extrapulmonary manifestations of mycoplasma, neurological involvement stands out amongst all others. So therefore, if they have an observation that it was positive in PCR as was a serology with a kind of a of 4 cases reported of a posterior stroke, it is quite likely. And there was a time when encephalitis was considered to be one major cause was mycoplasma when the California encephalitic study was done. And so azithromycin was part of a protocol for treatment of a CNS manifestation.
So I think that's all from this side. So it was really a wonderful discussion, and I would like to have a comment from Dr. Palani.
As a person doing a lot of otoscopy, at least I used to see at least one case of bullous otitis meningitis, textbook picture of bullous meningitis once a month. But as like pneumonia, like younger the age group, pneumococcus is the commonest reason for bullous meningitis. Older the age group, like 7 years, 8 years, the two reasons are either influenza or mycoplasma. Either it can be. These are the either viral bullous meningitis or it can be atypical bullous meningitis, not a pneumococcus in the older age group. Younger the age, pneumococcus is the commonest cause.
So, Palani, do you think that 9-year-old child had mycoplasma?
That picture is not that picture is not a bullous meningitis.
Not a bullous meningitis.
Not a bullous meningitis. It's a simple minimal effusion. That's all.
Palani, how did you prove pneumococcal otitis media?
Sir, only therapeutic. It's a high fever thing and therapeutic only. Nothing.
But otitis media can resolve without antibiotic also.
But such a toxicity you can't think. This is the picture. This is a typical picture of bullous otitis media, sir.
Yeah, this is what
classical picture, sir. And really, the patient responds very well in 48 hours with amoxicillin. Just amoxicillin only.
Thanks, Dr. Palani, for sharing this.
Yes.
This is a really clear picture.
Yeah, good.
So now, lastly, I think I would like to have comments from Dr. Darur, sir.
Even that mycoplasma-induced mucositis and rash also, we had seen a few cases which responded very well to doxycycline. We used to use doxycycline, particularly with respect to skin and to cover both staph as well as mycoplasma. So it responded very well to, because that was also one entity which is commonly we are seeing here.
And before Dr. Darur, sir, Dr. Rashna wants to comment because she has also put few comments of her cases.
No, we are seeing a lot of, I am actually seeing a lot of known cases of asthma, which are getting fresh fevers and not responding to the adequate therapy. So therein, actually, just when the meeting started, I got one of my patients send me the report, Mycoplasma IgM positive, and that I had started empirically. So she has responded. So I'm seeing even younger patients. So I think we just need a high index of suspicion, but the discussion was great, though confusing in some places. But I'm always using oral azithro. I don't have the guts to use IV as yet.
So Chitkara, Bala and Sham would agree that we really enjoyed arguing, agreeing, disagreeing and reasoning today.
It is like boxing,
That's why you have panel discussion, no?
You get all the energy to box.
That's why you have panel discussion.
We didn't have any moderator this time. It were all experts. Anyways, Dr. Darur, sir.
The umpire is sitting outside holding the towel to throw into the boxing ring. It was like that. They went on exchanging their views, and it was very lively one. But as they said that it is the CNS that is the commonly involved as a complication later. So the features will be what is cerebellitis. You see transverse myelitis and encephalopathy and aseptic meningitis. These are the common CNS manifestations of mycoplasma. With this, I think extensively discussed about a very small item all these days, but this is the most important one that is going to come up in the future, because what we learn today, we start searching for it and we find the numbers increasing suddenly. It is there, but we have to identify depending upon our clinical ability and suspicion, try to progress further to treat in a better way all the patients. Thank you for this lively session. I think this was the best one of the 11.
I think Dr. Pramod Shokar is there.
Chetan, one question. None of them had seen the cases that I showed today. Neither Sham nor Chitkara nor Bala. And their comments were, what they...
It would not have created any difference.
Sir, the first request...
So they were candid. Like Sham said that he does use doxycycline in one of the... Yeah.
No. No, no. First request for Subramaniam was that no one should know the cases. At the first time when I asked for this sessions, said, sir, don't reveal them. Let them give their original opinions, no modified or dictated opinions. So that was today what I have seen in this discussion.
And lastly, if Dr. Pramod Jog sir is there.
Jogonomics.
Sorry.
Yes, Dr. Ravi Shankara.
There is nothing actually.
Yeah,
All
this is the case. No, this is the case which I got mycoplasma proved by both by IgM, and patient has got myocardium ischemic like pictures where ST segment is low. Hello, can you hear me?
Yes.
Yeah.
There is Yamaha. There is the ST segment is low and abnormal T waste. Serum mycoplasma IgM positive and RT-PCR also positive and responding to the azithromycin. And this is before giving the azithromycin to take. And this is the picture. So patient has got troponin I also more than 30. So there is a myocardial ischemia is there in this case. That's why I wanted to show as it is rare. Sorry to interfere in between.
No. It was always
Yeah.
useful. Thank you so much. You can
But
just
how do you
stop
explain
sharing.
that? Shyam Balan Chitkara, how do you explain this ischemic injury to the heart?
Sir, the myocarditis.
Myocarditis is known, but
Yeah,
this
so
kind of
I tell you,
ischemic.
in 2008, I wrote one case on mycoplasma myocarditis in a 9-month-old child with IgM positive with all these features of these non-specific STT changes. No journal accepted because they wanted PCR at that time, and we did not have access to PCR at that time. So my article was rejected by 5 international and national journals just because I didn't have access to PCR. But I do agree that the ischemic changes, myocardial damage, with having ruled out all other alternative causes of myocarditis in an infant or in children, is quite possible with mycoplasma. It's more of a vasculitis kind of a phenomena.
Yes, Dr. Jog sir. Jogonomics.
No, nothing. Actually, I must congratulate Vijay, Sham, Bala, and Chitkara. And all the panelists were saying, they eat mycoplasma, they drink mycoplasma, they breathe mycoplasma. But for the listeners now, it is now time to say, I sleep mycoplasma. Thank you.
Thank you.
You sleep mycoplasma.
Okay, thank you so much.
Thank you
everyone,
so
once
much,
again.
and good night.
Good night.
Thank you.
Thank you all, one and all.
Thank you.
Nice session.
Thank
Nice
you. Good
session.
night. Good night.
Good night, sir.